Hi, Dr. Vinay Chandran. Welcome. Prasanna Madam, I think. Prasanna Madam, you have joined. Radhamani Madam. ആരുടെയും ക്യാമറ ഓൺ അല്ല. ഡോക്ടർ വിനയ് ചന്ദ്രന്റെ മാത്രമേ കണ്ടുള്ളൂ ക്യാമറ. മ്യൂട്ടഡ് ആണ്. ഡോക്ടർ വിനയ് ചന്ദ്രൻ മ്യൂട്ടഡ് ആണ്. അൺമ്യൂട്ട് ചെയ്യണം തോന്നുന്നു. ആ ഇല്ല, കേൾക്കാൻ പാടില്ല. ഇപ്പൊ കേൾക്കായിരിക്കും സംസാരിച്ച. ഇപ്പൊ കേൾക്കാം. പക്ഷെ വോയിസ് ഭയങ്കര ഫീബിൾ ആണല്ലോ. ഒന്ന് ഉറച്ച് സംസാരിച്ച് നോക്കി. എന്തെങ്കിലും പ്രോബ്ലം ഉണ്ടോ? ഇല്ല, കേൾക്കുന്നില്ല. ഹലോ മാഡം. മാഡം ക്യാമറ ഓൺ ചെയ്ത് കാണത്തില്ല. ഞാൻ ക്യാമറ ഓൺ ചെയ്തിട്ടില്ല മാഡം. അതുകൊണ്ട് എന്നെ കാണാത്ത.
ഞാൻ ക്യാമറ ഓഡിയോ വീഡിയോ ഒക്കെ ഓൺ ചെയ്ത് വെച്ചിരിക്കുക. വേറെ ആരും കേറിയില്ലേ? ലക്ഷ്മി,
ശ്രീദേവി മാഡത്തിന് ആരെയും കാണുന്നില്ല എന്ന് പറയുന്നു.
അതിന് പിന്നെ ലിങ്ക് ശരിയാണോ?
മാഡം ഒരു സെക്കൻഡ്. ഞാൻ ഇപ്പൊ വരാവേ മാഡം, ഒരു സെക്കൻഡ്.
Hello, Lakshmi Amma, can you hear now?
ഇപ്പൊ കേൾക്കാൻ തോന്നുന്നു അല്ലെ? മാഡത്തിന് കേൾക്കാവോ ഡോക്ടർ വിനയന്ദ്രൻ സംസാരിക്കുന്നത്?
എനിക്ക് കേൾക്കാം.
Madam,
ഗുഡ് ഈവനിങ്.
കേൾക്കാം.
good evening. നല്ല സ്റ്റൈലിലാണല്ലോ.
എന്ത് സ്റ്റൈല്?
എപ്പോഴാണ് സ്റ്റൈല് കുറവ്?
പിന്നെ എന്തിന്റെ സ്റ്റൈല് കഴിഞ്ഞിട്ടല്ലേ ഉള്ളൂ.
ഓ
പിന്നെ അതെ,
ഓ
പിന്നെ
ബ്ലൂടൂത്ത്
മൂന്ന് ഡോട്ട് കാണുന്നതിനകത്ത് എന്തോ
ഓൺ ചെയ്യോ?
ഡോട്ട് കാണുന്നില്ല.
ഏ?
ഞാൻ ബാക്ക്ഗ്രൗണ്ട് ബ്ലർ ചെയ്തിരിക്കുക.
ഇത് തരും ചോദിച്ചോ?
ബ്ലർ വേണ്ടാന്ന് എനിക്ക് തോന്നി.
എന്തെങ്കിലുമൊക്കെ മറന്നു ഇവരെ
മാഡം
ഇൻട്രൊഡ്യൂസ്
വീട്ടിലാണോ അടൂരാണോ?
എന്റെ ബെഡ്റൂമിൽ തിരുവനന്തപുരത്ത്
ശരി.
പിള്ളേര് വരും, അതുകൊണ്ട് ഞാൻ അതിനകത്ത് കയറി അടച്ചിരിക്കുക, ഇല്ലെങ്കിൽ പിന്നെ ഭയങ്കര ബഹളമായിരിക്കും.
ഉം.
Good evening, Prasanna Madam.
ഗുഡ് ഈവനിങ് ചിത്ര.
Good evening, MDNMSR sir.
Good evening, good evening.
സുചിത്ര മാഡം, ഗുഡ് ഈവനിങ്.
എവിടെ
madam.
എന്തെങ്കിലും കാണുന്നില്ലല്ലോ.
ഞാൻ എന്റെ
ലക്ഷ്മി
ക്യാമറയ്ക്ക് ഒരു പ്രശ്നമുണ്ട്, നോക്കട്ടെ മാഡം, ശരിയാവുമായിരിക്കും.
Okay, good evening.
എപ്പോഴും ഞാൻ ബിഹൈൻഡ് ദ കർട്ടൻ ആണ് മാഡം.
पर्दे के पीछे.
സുചിത്ര പറഞ്ഞേക്ക് ആകെ.
ആണോ?
വിനേന്ദ്രൻ ഇരിക്കുമ്പോ സൂക്ഷിച്ച് പറയണം കേട്ടോ, ഇല്ലെങ്കിൽ കിട്ടും.
सुभाष गाड़ी में चलता है.
Yeah.
സുഭാഷ് ഓൾവേസ് ഗാഡി മേ ഓർ തിയേറ്റർ മേ.
गाड़ी या थिएटर या പറക്കുന്ന ഫ്ലൈങ്.
ഇല്ല മേഡം, ഞാൻ കഴിഞ്ഞ മേഡം എല്ലാം കഴിഞ്ഞ വീട്ടിലേക്ക് പോയിക്കൊണ്ടിരിക്കാം മേഡം.
വീട്ടിലേക്ക് പോകും.
ഗുഡ് ഈവനിങ് മേഡം, പ്രശ്നം മേഡം, ഗുഡ് ഈവനിങ്, സുചിത്ര മേഡം, ഗുഡ് ഈവനിങ്,
Good evening, good
ലക്ഷ്മി
evening.
മേഡം, ഗുഡ് ഈവനിങ്.
പ്രശ്ന മാഡം, എന്തായാലും നമ്മൾ ആ തലേന്ന് ഇത് 23rd ഇത് കണ്ടക്ട് ചെയ്യാം. We will
അവര്
do it.
പ്രോഗ്രാം ഒക്കെ ആക്കാൻ പറഞ്ഞാൽ മതി.
ആ,
ഞാൻ എന്തൊക്കെ അവര് എന്നെ ഒന്ന് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യുമ്പോൾ ഞാൻ അറിയിപ്പിക്കാം എന്തൊക്കെ പറയാന്നുള്ളത്. കുറച്ച് കാര്യങ്ങൾ ഞാൻ സംസാരിക്കാന്ന് വിചാരിച്ചു.
ഏതായാലും മാഡം ഇത്രയും ദൂരം വരുമ്പോ നമുക്ക് രണ്ട് കാര്യം ഒരുമിച്ച് ചെയ്യാം.
ഒന്നിച്ച്
ഉം.
2-3
അന്നേരം
ഒന്നിച്ച് നമുക്ക്
nurses-
വിചാരിച്ചില്ല, പക്ഷെ പറ്റിയില്ല.
എന്താ മാഡം?
ഞാൻ അവിടുന്ന് പിന്നെയും കാസർഗോഡ് എന്നൊക്കെ ആലോചിച്ചതാ, പക്ഷേ പിന്നെ വേണ്ടാന്ന് വെച്ചു. ആരോഗ്യം മോശമാണ്. പക്ഷെ കുഴപ്പമില്ല, ഈ കാല് നടക്കാനുള്ള ഇതാണ്.
നേഴ്സസിനെയും മറ്റേ ഡോക്ടേഴ്സിനെ രണ്ടും വിളിക്കണോ? അല്ലെങ്കിൽ വെറും ഡോക്ടേഴ്സാ?
നഴ്സസ് വേണം.
നേഴ്സസിനെ വിളിക്കുന്നില്ല, നല്ല
വേണം.
കുറച്ചും കൂടി എല്ലാവർക്കും ഒരു അവയർനെസ് വരൂലേ?
എല്ലാരും ഒരു ടീമായിട്ട് പഠിച്ചാലേ പറ്റുള്ളൂ.
അതെ അതെ. അതുകൊണ്ട്
അങ്ങനെ
എല്ലാരും
വിളിക്കുന്നു. എല്ലാരും അങ്ങനെ
വിളിക്കും. ഡിഎംഒനോട് പറഞ്ഞിട്ടുണ്ട്.
സ്പെഷ്യലി DMO ആർസിസി ഓഫീസറും വരും.
ആർസിസി ഓഫീസറിനോട് പറഞ്ഞിട്ടുണ്ട്.
പിന്നെ ഞാനൊരു ട്രെയിനേഴ്സ് പുതിയ കുറച്ച് പേരെ ട്രെയിൻ ചെയ്ത് എല്ലാ ഡിസ്ട്രിക്റ്റിലും എടുത്ത് ട്രെയിൻ ചെയ്യാമെന്ന് മനസ്സിൽ വിചാരിക്കുക. അപ്പൊ ഞാൻ അവിടെ പറഞ്ഞിട്ടുണ്ട്, ഞാൻ ശ്രമിക്കുന്നുണ്ട്. ഒരു ഗവൺമെന്റ് ഗസ്റ്റ് ഹൗസ് ഉണ്ടല്ലോ, അവിടെ ആണെങ്കിൽ പിന്നെ വർക്ക് സ്റ്റേഷൻ ഉണ്ട്, മറ്റേ ട്രെയിനിങ് കൊടുക്കാൻ വേണ്ടിയിട്ടേ. സാധനങ്ങളുണ്ട്. അവിടെ വെച്ചൊരു ട്രെയിനിങ് അങ്ങോട്ട് അറേഞ്ച് ചെയ്ത് ട്രെയിനർ ഒന്നുകൂടെ നടത്താൻ വിചാരിച്ചിരിക്കുക. ശ്രമിക്കുന്നുണ്ട്, പക്ഷെ ഗവൺമെന്റിന്റെ കാര്യമല്ലേ.
ഹലോ, ഗുഡ് ഈവനിങ് വസന മാഡം,
ഗുഡ് ഈവനിങ്
സുചിത്ര മാഡം, വിനയചന്ദ്രൻ. എന്നാലും പ്രസിഡന്റിനെ കയറി അങ്ങനെ വെറുതെ പേര് വിളിക്കാം.
എന്നെ പേര് വിളിച്ചാൽ മതി, കുഴപ്പമൊന്നുമില്ല. എനിക്ക് മാഡം പേര് പറയുന്ന ഇഷ്ടം.
ശരി ശരി. കാണാം.
വേണു സാറാണോ ഹെൽപ്പ് ചെയ്യുന്നത്?
അതെ അതെ, എനിക്ക് കിട്ടുന്നില്ലായിരുന്നു, കിട്ടിയില്ല.
സെക്രട്ടറി ഉണ്ട് ഫുൾ ടൈം.
അല്ലെ, കിട്ടുന്നില്ലായിരുന്നു. അത് പണ്ടേ കിട്ടുന്നല്ലേ വേണു സാറിന്?
അതൊന്ന് അടച്ചേക്കണേ, ഞാൻ പുറത്തേക്ക്.
AC ആണ്. ഭയങ്കര ചൂട്.
പേരിട്ടാലോ ഫാക്കൽറ്റി എന്നുള്ളടത്ത്.
ആ ഡോട്ട് ഒന്ന് ഇതാക്കിയാൽ മതി എല്ലാവരും.
ആ 113 പേരായി.
ഓ 114 സെഞ്ചുറി കഴിഞ്ഞു.
യൂഷ്വലി 270 അങ്ങനെയൊക്കെയാണ്.
എല്ലാരോടും ലോഗിൻ ഇങ്ങനെ റിമൈൻഡ് ചെയ്തുകൊണ്ടിരിക്കുന്നുണ്ട് ഞാൻ.
സുചിത്ര ഇടയ്ക്കിടയ്ക്കെല്ലാം ഇട്ടോണ്ടിരിക്കും.
Good evening, madam. Good evening, madam.
ഗുഡ് ഈവനിങ് അജിത് സർ.
Sir, Videndra sir, Sridevi madam.
അന്ന് എപ്പോ ചെന്ന് അജിത്തെ തിരിച്ചു?
രാത്രി 10:30 സാറേ.
ആണോ?
വന്ദേ ഭാരത് അല്ലേ?
താങ്ക് യു ഫോർ കമ്മിങ്.
ശരിക്കും നല്ല പ്രോഗ്രാം ആയിരുന്നു സാറിന്റെ കോളേജിലെ. നല്ല CMA ആയിരുന്നു. നല്ല
ടോപ്പിക് എല്ലാരും പറഞ്ഞു, നല്ല ടോപ്പിക്സ് ആയിരുന്നു.
അതെ
കുറച്ചുപേര് വന്നിട്ടില്ലായിരുന്നു.
ഹായ് അജിത്.
മാഡം.
ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ്.
കുറെ നാളായല്ലോ.
മാഡത്തിനെ കാണുന്നില്ലല്ലോ. പ്രസന്ന മാഡം മാത്രമേ കറക്റ്റ് ആയിട്ട് ഇരിക്കുന്നുള്ളൂ.
നേരത്തെ ഒന്ന് കണ്ടു.
അജിത് സാർ, ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ്. ഗുഡ് ഈവനിങ് സുഭാഷ്.
സാറേ പ്രോഗ്രാം നല്ലതെന്ന് വെച്ചാൽ വിനേന്ദ്ര സാറല്ലേ സാറേ സയന്റിഫിക് കമ്മിറ്റിയുടെ ഹെഡ്. അപ്പൊ എന്തായാലും നല്ലതാവില്ല സാറേ. ജസ്റ്റ് അക്കൗണ്ട് സാറ് തന്നെയാ സാറേ.
ജസ്റ്റിഗോഡ് സാറ് തന്നെയാണ്.
ഞാൻ അതിനിടയ്ക്കൊന്ന് ജസ്റ്റ് അക്കൗണ്ടിൽ പുകഴ്ത്താൻ നോക്കിയാ സാറേ.
പ്രോഗ്രാമാണ് ഏറ്റവും ഇമ്പോർട്ടന്റ് ആയിട്ടുള്ളത്. കുറെ CMEs ഒക്കെ ഉള്ളതുകൊണ്ടേ നല്ല പ്രോഗ്രാം ഉണ്ടെങ്കിൽ മാത്രമേ ആൾക്കാർ വരത്തുള്ളൂ.
ഒരു MDNMSR വെച്ചാൽ മതി. ഇപ്പൊ 135
200 ഒക്കെ കഴിയുന്നതാണ്.
അത് കുറച്ച് കഴിയുമ്പോൾ 200 ആവും.
ശബ്ദം കേൾക്കാം.
ഇതിനകത്ത് ഔട്ടാണ്.
സ്ക്രീനിലൂടെ തന്നെ
കേൾക്കാം.
അധാമണിയുടെ കയറിയിട്ടില്ല തോന്നുന്നു.
ഹായ് സംഗീത.
ഹലോ മാഡം.
ഹലോ.
ഇതെവിടെ, ട്രിവാൻഡ്രമാണോ ആലപ്പുഴയാണോ?
ആലപ്പുഴയൊന്നും അല്ല, ഇന്ന് ബാംഗ്ലൂരാണ്.
ഓ എന്റെ അമ്മ.
സംഗീതയുടെ ഫേവറേറ്റ്
വീട്ടിൽ ഇല്ല മാഡം, ഞാൻ ഹരി ഇവിടെ ഉണ്ടായിരുന്നു. എനിവേ സോ ഐ കെയിം ഫോർ വൺ ഡേ. ഐ എം ഗോയിങ് ബാക്ക് ടുമോറോ.
ഓക്കെ.
Your shoulder is okay, Sangeeta?
Yeah, much better. Much better. Thank you so much.
എന്ത് പറ്റി?
Very much better. ഷോൾഡർ സാറേ എന്തൊക്കെയോ സംഭവിച്ചു, എന്താന്ന് എനിക്ക് അറിഞ്ഞൂടാ. ഇറ്റ് ടുക്ക് മീ എ ഇയർ. ലാസ്റ്റ് AKCOGക്ക്
കുറെ
തുടങ്ങിയ
നാളായില്ലേ?
പരിപാടി
കുറെ
കുറെ
നാളായി.
നാളായി. ഇപ്പൊ എക്സസൈസ്, ഒരു ഫിസിക്കൽ മെഡിസിൻ ഡിപ്പാർട്ട്മെന്റ് GH പോയി ഒരു സെറ്റ് ഓഫ് എക്സസൈസസ്. പെർഫെക്റ്റ്, ഇറ്റ് വർക്ക്സ്.
എന്താ കഫ് പോയതാ? റൊട്ടേറ്റർ കഫ്.
റൊട്ടേറ്റർ ആണോ എന്തിനാണോ എന്തോ കപ്പ് പോയി
എന്തോ പോലെയല്ലേ?
എന്തിനാണോ
സാറേ. ഒരു ദിവസം പൊക്കാൻ വയ്യ കയ്യ്. എന്തായാലും ഇപ്പൊ ശരിയായി.
കുറച്ച് നാളായില്ലേ ഇത്?
1 year മാഡം, 1 year.
1 year.
അത് അന്ന് ഇറ്റ് വാസ് അക്യൂട്ട്. അതാണ് എനിക്ക് ഏതോ ഒരു കോൺഫ്യൂഷൻ. ഐ കാൻറ്റ് റിമെമ്പർ വിച്ച്. ഐ കുഡ് നോട്ട് ട്രാവൽ ബിക്കോസ് ഓഫ് ഇറ്റ്.
Yeah.
അത് 1 at ആലുവ ആഡ്ലക്സിലുള്ള. കറക്റ്റ്.
റെഗുലറായിട്ട് ഫിസിയോതെറാപ്പി ചെയ്ത്
അതെ,
ഇരിക്കാൻ
ഞാൻ മാഡത്തിന്റെ
സർജറി
ഐ
ചെയ്താൽ
നോ
ഭയങ്കര കഷ്ടപ്പാടാ.
കറക്റ്റ്.
ഭയങ്കര പോസിബിലിറ്റി പെയിനാ.
നല്ല ഫിസിയോതെറാപ്പി സെന്റർ ഉണ്ട്, ഞാനിപ്പോ അതിലാണ്.
ആണല്ലേ?
മാഡം,
അയ്യോ,
രാധാമണി
അതൊന്നും
രാധാമണി മാഡത്തിനെ കേറാൻ പറ്റുന്നില്ല എന്ന് പറയുന്നു.
ആണോ?
എന്താണ്
അയ്യോ.
രാധാമണി മാഡത്തിന് എല്ലാം കേൾക്കാം. പക്ഷെ രാധാമണി മാഡം കയറിയിട്ടുണ്ടെങ്കിൽ ഒന്ന് സംസാരിക്കുമോ മാഡം?
രാധാമണി എന്നെ വിളിച്ചോണ്ടിരിക്കുന്നേ. ഹലോ രാധാമണി.
രാധാമണിയുടെ ഏത്
രാധാമണി
ലിങ്കിലാണെന്ന് നോക്കണേ.
കേറാൻ
ഫാക്കൽറ്റി
പറ്റുന്നില്ല.
മറ്റേ ലിങ്കാണോ?
മറ്റേ ലിങ്ക് ആണോ?
പാക്കറ്റിലാണോ?
ചിലപ്പോ ഡെലിഗേറ്റ് ലിങ്കിലായിരിക്കും കയറിയത്, അതുകൊണ്ടാണ്.
ഇല്ല, ഡെലിഗേറ്റ് ലിങ്ക് ഇട്ടിട്ടില്ല മാഡത്തിന്.
അതെയാ?
ഇപ്പൊ നമ്മള് തന്നെ
ഞാന് എല്ലാ ഗ്രൂപ്പിലും ഇട്ടിട്ടുണ്ടല്ലോ, ചിലപ്പോ അതില് കയറിയിട്ടുണ്ടാവും.
രാധാമണി കേറാൻ പറ്റുന്നില്ല.
മാഡത്തിന് മെയിൽ ID വല്ലതും അയച്ചു കൊടുത്തു കഴിഞ്ഞാലേ, മെയിലിൽ വല്ലതും അയച്ചു കൊടുത്തു കഴിഞ്ഞാൽ
രാധാമണിക്ക് കേറാൻ പറ്റുന്നില്ലേ?
ഞാൻ വിളിക്കാം മാഡം, ഞാൻ വിളിക്കാം.
ഞാൻ വിളിച്ചോണ്ടിരിക്കുക. ഹലോ.
ഒന്നുകൂടെ മെയിൽ ഐഡിയിൽ അയച്ചാലോ ലക്ഷ്മി?
അത് ശരി. അപ്പം ഞാനൊന്ന് പറയട്ടെ. ഹലോ അജിത്. ആരാ? ഹലോ അജിത്തെ. രാധാമണിക്ക് നമ്മൾ പറയുന്നതൊക്കെ കേൾക്കാം, പക്ഷെ രാധാമണിയുടെ എന്തൊന്നും ഇങ്ങോട്ട് വരുന്നില്ല.
ഡെലിഗേറ്റ് ലിങ്കിനാണോ കയറിയേക്കുന്നത് മാഡം?
ഡെലിഗേറ്റ് ലിങ്ക് ആണ് മാഡം. അത് മാറിയിട്ട്
ഡെലിഗേറ്റ് ലിങ്കിനാണോ കയറിയേക്കുന്നത് നോക്കണം.
ഫാക്കൽറ്റി ലിങ്ക് കയറട്ടെ. ഒന്നുകൂടെ മെയിൽ അയച്ചാലോ ലക്ഷ്മി?
അയക്കാം മാഡം, ഞാൻ ഇപ്പൊ അയക്കാം.
എല്ലാം ഓഫ് ചെയ്ത് പുതിയ
അജിത്
മെയിലിൽ കയറാം.
സർ, രാധാമണി മാഡം ഫാക്കൽറ്റി ലിങ്കിനാണ് ഉള്ളത് സാറേ.
ആണോ?
കഴിഞ്ഞ പ്രാവശ്യം എനിക്ക് ഇതേ പ്രോബ്ലം ഉണ്ടായിരുന്നു.
രാധാമണി മാഡം ഐപാഡ്.
I had the same problem last time actually.
ഹലോ.
ഇപ്പൊ കാണാമല്ലോ. രാധാമണി മാഡം ഉണ്ട്, ഫാക്കൽറ്റി ലിങ്കിൽ ഉണ്ടല്ലോ.
അല്ല, രാധാമണി മാഡം എന്താ പറഞ്ഞേ?
അല്ല, എന്നെ കാണാമോ?
മാഡത്തിനെ കാണാൻ വയ്യ, മാഡത്തിനെ കേൾക്കാം ഇപ്പൊ.
ഇപ്പൊ കാണാം, കാണുകയും ചെയ്യാം.
ഇപ്പം കാണുന്നുണ്ട്.
ഇപ്പൊ കാണാം.
ഞാൻ കാണുന്നില്ലല്ലോ.
Now we can see.
Sir, shall we start? Madam, shall we start?
Tried several devices, iPad, iPhone.
748. 740.
അല്ലെങ്കിൽ ശബ്ദം എക്കോ ചെയ്യും.
സ്റ്റാർട്ട് ചെയ്യാം.
സ്റ്റാർട്ട് ചെയ്യാം, അല്ലെങ്കിൽ താമസിച്ചു.
ഹലോ.
Avani, can I call you later? I'm on a Zoom. Okay.
Madam, shall we start, madam?
Yeah.
Ah, ലക്ഷ്മി പിന്നെയും പോയോ?
മിനി കേക്കാമോ?
180 ആയി.
മാഡം ഇത്രയും നേരം പറഞ്ഞത് കേക്കായിരുന്നോ?
കേൾക്കാം
ആ.
കേൾക്കാം.
കേക്കാം.
ആ.
സ്റ്റാർട്ട് ചെയ്യാൻ
മിനി
ലക്ഷ്മി.
അടുത്ത സ്ലൈഡ് ഇടാമോ? അടുത്ത നെക്സ്റ്റ് സ്ലൈഡ് പ്ലീസ്.
മിനിയെ നമ്മൾ കാണുന്നില്ലല്ലോ.
അല്ല മിനി അല്ലേ മാഡം പ്രസന്റ് ചെയ്യുന്നത്, അപ്പൊ രണ്ടുപേര് കയറണ്ടെന്ന് വിചാരിച്ചു. മിനി അടുത്ത സ്ലൈഡ്. മിനിക്ക്
ഒരു
കേൾക്കാമോ?
മിനിറ്റ് മാഡം. എനിക്ക്
ആ.
കേൾക്കാം മാഡം. അത് മൂവ് ചെയ്യുന്നില്ല. ഒരു മിനിറ്റ്. നേരത്തെ മൂവ് ചെയ്ത് വരുന്നു. ഒരു സെക്കൻഡ്.
ഞാൻ കണ്ടിന്യൂ ചെയ്യാം.
ഇൻട്രൊഡക്ഷൻ പറഞ്ഞാലോ ലക്ഷ്മി, ഒരുപാട് പേര് വെയിറ്റ് ചെയ്യുന്നുണ്ട്.
അതെ. Now we start the program with gratitude to Dr. V.P. Paili, who is the brain behind the MDNMSR activities of Kerala. Now we come to Dr. Prasanna Kumari. We know the MDNMSR committee is under the Safe Motherhood Committee, and Madam is the chairperson of the state state chairperson of the Motherhood Committee. And I have always had been telling that we have a great support from the chairperson. Madam, very much interested in continuing with the activities and choosing the topics and going through it. And I need to introduce Dr. Prasanna Kumari to the August crowd, to the crowd of gynecologist crowd of Kerala. And she is a teacher of thousands of gynecologists in Kerala and still continuing to teach. She is an expert professional, a surgeon, and a great teacher. And then we come to Dr. N.S. Sridevi, Madam. And we welcome you, Madam. Of course, I need to welcome Prasanna, Madam, because she is one among us. And Dr. N.S. Sridevi, Madam was the past president of KFOG, now national president of the study of the trophoblastic disease of India. And she has worked as professor of obstetrics and gynecology in various government medical colleges, head of the department at Pushpagiri Medical College, and now working as senior consultant in SP Welfare Trivandrum. More than any of this, she is an ardent teacher, a teacher of the gynecologists of Kerala, now also continuing pursuing with her teaching activities for the postgraduate students. Madam, now as you all agree, Madam is as sweet at heart, as sweet as she looks, with full of affection and simplicity. With these words, I welcome Sridevi Madam to today's discussion. And Radhamani Madam, she had been the professor and HOD at Medical College Kottayam, SUT Medical College Vattapara, and Travancore Medicity. She is the former senior consultant at KIMS Hospital Trivandrum. I am lucky that I had the fortune to work with Madam at SUT Vattapara and have known her personally and professionally. As a professional and teacher, I have just one sentence to say, or to quote, "Perfection, thy name is Dr. Radhamani." Even now, she is very sincere in taking classes for the DNB students and also for the MDNMSR discussions for the various districts. And now we come to the Dr. Vinay Chandran. He also had been the past president of KFOG. Presently, he is the professor and head of the department at Malabar Medical College, Calicut. He was the former professor and HOD at Government Medical College, Kannur and Manjeri, and professor of obstetrics and gynecology at Calicut Medical College. And I don't have much personal association with Dr. Vinay Chandran, but he had been a very active presence in all our CRMDs, EMOCALs, etc. And we welcome you, sir, to this discussion. Now
Thank
we
you.
come to the young and vibrant Dr. Mini. She is at present a consultant in ONG at Government Hospital, Kottayam. But I know her as an MDNMSR chairperson, a captain at Kottayam. And she has been very, very active in the MDNMSR activities, sending cases, and whatever help I need, it comes within minutes. Thank you, Minnie, for accepting our this thing as a role as a presenter. And with these words, I think, next slide, please.
President and Secretary.
Minnie, and the madam?
President and Secretary പറഞ്ഞില്ലല്ലോ.
മാഡം ഞാൻ അതാ ചോദിച്ചത്, ഞാൻ പറഞ്ഞു എന്നുള്ളത് ഞാൻ ഓൾറെഡി ആദ്യമേ പറഞ്ഞ അതായിരുന്നു. ഞാൻ അതാ ചോദിച്ച കേൾക്കാമോ എന്ന്. ബിഫോർ ഐ ഗോ ടു ദി ഇൻട്രൊഡക്ഷൻ, അത് എനിക്ക് എന്തോന്ന് എന്റെ ഓഡിയോ ഇപ്പൊ മ്യൂട്ട് ആയിരുന്നെന്ന് തോന്നുന്നു. And I said, yeah, before I begin to go to the experts, the VIPs of the day, Dr. Sujitra, the KFOG president, and Dr. Subhash Malya, the secretary of KFOG. I had already welcomed them, but I think it was muted.
Ajit.
And I know all of them are very busy, but then Dr. Sujitra had in fact put the flyer in KFOG group before I put it. And madam remembered that it was the MDNMSR webinar day and she had put it. Thank you, madam. Thank you very much. Dr. Subhash said he was active in the operation theater, but he would find time to join. Dr. Subhash Malya, your presence, both your presence is, we value it much. Dr. Kunjumaideen is out of India, so he said he may not be able to join. Dr. Ajit, the state coordinator, has already joined, and we welcome you all to the MDNMSR webinar, and we expect and we hope to have your participation in future webinars also. Thank you so much. Now, with this, I invite Minnie for the case presentations. And before she begins, I want to say we have 7 cases. That's why we wanted to start at 7:30 itself. And I think the delegates had joined, but then we had some problem with this technical problems. But anyway, we have 7 cases of rupture uterus, which we had more cases. We have selected 7, and 3 we are going to discuss a bit in detail, and half an hour for each case, 3 cases, and then 5 minutes each for the short discussions. We have presented how the rupture occurred in each of those 4 cases, and opinions will come from the experts. Okay. Now with this, we go on to the case
sorry, ma'am. Dr.
presentation.
Kunjumaideen is also joined, ma'am. Dr. Kunjumaideen is over here. Dr. Kunjumaideen,
I
Dr.
know.
Sangeeta. Good
Dr.
evening, ma'am.
Kunjumaideen,
Dr. Sangeeta
welcome.
also. Dr. Sangeeta, madam also.
Okay.
Yeah,
And
thank you. Thank you. Thank you. Best wishes.
Before Minnie goes into the topic, maybe I would request the state president, Dr. Sujitra or Dr. Subhash Malya, to say a few words. If you want to talk about the MDNMSR or how we should improve, you can please talk. Because the time was delaying, I just forgot about this.
Actually,
Sujitra, madam.
good evening to all. It is with great pleasure that I'm witnessing the 4th MDNMSR webinar. And I really congratulate Dr. Lakshmi Ammal because she's very consistent and very dedicated. And we know that the motivation comes from our Prasanna madam, our Ajit sir, because these webinars are very useful. It is something that we come face to face in everyday practice. And we are really hoping that every time there will be almost all the gynecologists would log in because we have a lot to learn. And Prasanna madam has the dream of making PPMD, preventable maternal deaths, 0 as far as possible. For that, we need to hone our skills and get tips from these sort of webinars. So thank you, Dr. Lakshmi Ammal, for giving me this opportunity to say a few words. And I really appreciate your work in this particular
Thank you.
field.
Thank you,
You are really
ma'am.
expert.
Thank you. Dr. Subhash Malya, as a secretary.
No, ma'am. Thank you, ma'am. We'll move over to the program. Ma'am. We'll move forward to the program. Thank you, ma'am.
Minnie, it's not out. Minnie?
Yes, sir.
Minnie,
Audible.
previous slides. Okay. Slideshow ഇടാൻ പറ്റുമോ?
Madam, slide show ഇടാം. Okay. Good evening, respected seniors and dear colleagues. I am presenting the first case, It's a 26-year-old primigravida, married for 6 years, IVF conception with regular ANC, no medical comorbidities. History of hysterolaparoscopy with myomectomy 6 months prior to IVF. No pregnancy-related complications. Reported to emergency department with lower abdominal pain and giddiness. Husband gave history of intake of tapioca, following which she had drowsiness. On examination, patient drowsy, responding to call, pallor present, cold clammy extremities, pulse rate 160 per minute, BP not recordable. Per abdomen diffuse tenderness present, uterus palpable 26 weeks, FHS good. Patient started on volume expanders and noradrenaline. 3 to 4 pints of blood were arranged. Anesthetist, OT staff, pediatrician were informed. HB 7.8, platelet count 3.7 lakh, LFT, RFT and coagulation factors within normal limits. Emergency ultrasound, single live fetus corresponding to 26 to 27 weeks with normal liquor and intact placenta. Plenty of free fluid in the peritoneal cavity. Emergency laparotomy done. Intraoperative findings, there was approximately 2 liters of blood and 500 grams of clots. There was a 3 into 2 centimeter rent in the posterior wall of uterus with a placenta protruding. LSES done and delivered live baby from uterine cavity, handed over to NICU, uterus exteriorized, posterior wall rent repaired, oxytocin given, uterine incision closed in layers, uterus contracted. Higher order antibiotics given, patient maintained on inotropes for 24 hours post-op, 2 more pint RBC transfusion in next 12 hours, physician consultation given. After 24 hours, hemoglobin 8.2, platelet 2.2 lakh. All other investigations, including coagulation profile, were within normal limits. Urine output was adequate. Drain showed 150 ml altered blood. Drain was removed on day 3. Patient put on thromboprophylaxis, 2 more unit of PRBC transfusion given, IV antibiotics and thromboprophylaxis continued, discharged on day 7. Total 2 unit whole blood, 5 pint PRBC and 2 pint FFP transfused. I invite Dr. Vinayendran sir for the discussion.
Many actually it was a good discussion to be done in this case, because when a patient comes with a previous history of myomectomy at nearly late second trimester or third trimester with in a collapse state, the 2 possibilities we often think of is, one is rupture uterus and the other one is abruption. In this case, more in favor of rupture uterus. Why? Because of this patient BP was nil with a tachycardia and peritoneal cavity contained fluid, and one good part is, and the FHS was present also. But maybe because the placenta might not have been separated and extruded into the peritoneal cavity. That may be the reason why FHS was present. And in such cases, we will have to do a scanning from the labor room itself, and then manage with a multidisciplinary team with blood and blood products. And regarding the rupture of the uterus, most of the time it will be a complete rupture, not a dehiscence. And the incidence of rupture vary from in open, it is around 0.6, whereas in laparoscopy myomectomy, it may be around 1%. In laparoscopy myomectomy, the rupture depends upon the surgical technique by which you close the myoma bed, will be an important factor in regaining the strength of the uterine scar. Excessive use of the electric cautery is one of the major disadvantages. If you are using excessive cautery, it produces necrosis and it produces decreased vascularity, and then the tensile strength of the scar will be low. Then the suturing technique, if you have to suture the myoma bed, ideally, if it is a deep myoma, that is figure 4 and 5, you will have to close by 2 layer. And if it is a superficial, that is 6 and 7, you can go by single layer closure. The most important factor in suturing is the approximation. If evenly placed sutures avoids hematoma formation, and the healing will be better. And another important factor which is coming up is that you will have to go by intracapsular extraction of the myoma, so that the capsule contains SP, that is substance P and VIP, that's vaso active intestinal proteins, which will help in healing of the wound. So if you go for intracapsular extraction, the healing will be better. Much more than that, the site of the fibroid and also the site of the placenta is also important regarding the chance for rupture. Most of the time, the rupture occurs in the third trimester, even before going into labor. And the immediate management is go for laparotomy and then do the cesarean and then close the cesarean wound after exteriorizing the uterus and then close the rupture site. So that was done in this case and excellently managed. They got the baby as well as the uterus. It was a good thing. They have done the right thing so that they have not missed the bus.
Thank you, sir. Radhavani madam, any other learning points other than sir?
Here, can you hear me?
Yes, madam.
Now, when we are doing it, as far as possible, when a patient is wanting to have a pregnancy, only do myomectomy only when it is absolutely indicated that the fibroid is the reason for infertility or RPL. Incidentally, finding fibroid should not be removed. That is one thing. And when you remove the fibroids in the report, that is in the operation notes, you have to write about the number of fibroids, the site of the fibroid, where you have put the incisions, how many incisions has been put. All these are should be recorded in the notes, or you can put a diagram of it also to the patient or in the record. And when the patient comes with a subsequent pregnancy, ideally it should be at least minimum 6 months, but ideally as for the myomectomy also better before the pregnancy. And when the patient comes with a pregnancy, you have to, when you do an ultrasonography, if you know the site of the fibroid myomectomy incision, you see whether the placenta location is there or not. Or even adherent placenta can occur following a myomectomy scar if it has been opened in the uterine cavity. And it's very important to localize the gestational sac, the placenta, etc. And thickness of the myometrium. When you do subsequent scans during the second or third trimester, you can at least look for any thickness of the myometrium or any abnormal echo pattern of the myometrium, which will tell you that there is a risk of this rupture in these patients. And closure, we have already said double layer closure, that is interrupted is better than continuous suture, because a continuous suture will produce avascularity and poor vascularization of the scar and resulting in a poor healing. That is all I have to say.
As madam said, we will have to mention also whether they have entered the cavity.
Yes,
that's also important.
Especially when you are doing a submucous type more than 2,
yes.
0, 1, 2, more than that, or when you are doing in a 3 or 4 type of submucous intramural fibroid, sometimes you may be inadvertently open in the uterine cavity. That should also be depicted in the only the subserous fibroids, which it is not entered into the uterine cavity, may not be much problem. But all other cases, it's very important to follow these patients, and inner surveillance is very, very important.
Even subserous, now they are saying that you have to suture it, because otherwise, if you are just fully cauterizing it, you are going to interrupt the myometrium, so that the necrosis can occur and it will produce a weak scar.
Also to suture it.
And regarding the interval between the myomectomy and the pregnancy, it's often said to be more than 6 months, but there are various studies that have shown that MRI has shown that the healing will be complete by 3 months. But it is better to delay the pregnancy at least for 1 year or so that you will get a better scar. Anything else, Vidya, madam?
Yeah, madam.
Hello.
Any other points to
Can
add?
you hear me?
Yes,
Yeah,
ma'am.
madam.
Yeah. Most of the points have been already covered, I think. Rupture, as far as we know, the literature says, and most of the time it is said in the literature that it is very often 0.05. But we can't believe that report, and we see more of cases, and many cases have been reported already. And many of the risk factors have been already mentioned. And here it was a uterine rupture after a laparoscopic myomectomy, which can happen even within a 6-month period. And here it is IVF conception. And due to the healing process of that lesion, there may be problems which can create scar rupture. So though lap myomectomy is minimally invasive, it still involves incisions that need a better healing. The risk of rupture is higher with larger fibroids, multiple myomas, or if the fibroid was located in a sensitive area of the uterus. Adding on to that, type of sutures used and the surgical technique can impair the strength of the uterine scar. That also we have to take care of. So with these points, I think I will stop.
The classical 3-layer rupture is less when compared to the scar distance, because we are most often seen when, especially with a cesarean scar, when you do the surgery, repeat cesarean section, you can see that there will be scar distance, but that is not taken into account most of the studies. That may be the reason why they are saying that it's less. So scar distance, if you include it, the incidence may be more.
But we cannot include scar distance into this group.
Yeah.
I think we'll ask Prasanna Madam her concluding remarks on this. Prasanna Madam. Madam muted ആണ് madam.
Prasanna Madam.
ഞാൻ ലക്ഷ്മി സംസാരിക്കാനായിട്ട് മ്യൂട്ട് ചെയ്താ പിന്നെ മറന്നുപോയി. The patient was actually very efficiently managed. Let us congratulate the team. That is the importance of having an ultrasound in the labor room, and every obstetrician should know how to do an obstetric ultrasound and how to make out all these complications which occur during labor. By ultrasound we could make we could have made out that the uterus, the fetus is still inside the uterus and there is blood in the peritoneal cavity, and so that immediately she has to be taken for laparotomy, and all the management correctly, baby as well as mother was saved, and the uterus also was saved. So that's one thing, and all other points have been discussed. And let me again stress that myomectomy as a reason for infertility is very, very less, because we have removed lot of fibroids, even larger ones measuring 2.7 kg along with cesarean. That means with fibroid, patients will conceive. So one thing I have to say is, as an incidental finding, Dr. Sridev Madam said, you find a 3 centimeter or 4 centimeter fibroid. Let us not remove it laparoscopically. So in the past few years, the rupture which I have seen, he followed laparoscopic myomectomy and adenomyomectomy. That this patient's fibroid, I think, need not have been removed, so that she would not have ended up with the rupture. So unless it is 0 or 1, 2 fibroid, that need not be removed as a reason, as a treatment for infertility. So I noticed that so many treatments for infertility, I'm not criticizing, are being done, which are actually not very necessary. These small fibroids, intramural, subserous removed. I know one patient who's, as a part of investigation for infertility, uterine sound went through the, perforated uterus. She went in for rupture at 29 weeks. So even a sound can cause rupture. Even passage of a sound can cause rupture. So when the patient comes for infertility evaluation, she should be properly managed. We should not cause infertility. We should not make her infertile. When she comes with complaints of having not conceived, it's our responsibility to evaluate her and treat her and do something which is necessary only. That's one thing. And as has been already stressed, we have to make a detailed note of the myomectomy, the size of the fibroid, the number of fibroid, the site of the fibroid, etc., etc., which already Dr. Adamani, all of them emphasized. So let us not do unnecessary myomectomies, especially laparoscopic. And when a patient comes, an antenatal patient comes, there can be very rarely spontaneous rupture also. An antenatal patient comes with pain abdomen, the pain has to be properly evaluated. You have to go in depth into the details of the pain and also examination, clinical examination, as well as ultrasound. An MRI is not necessary, and the thickness of the scar. Thickness of the scar, I don't think it is set 3 millimeter, 3.5 millimeter is okay. But I have tried several times to measure the scar, and I don't think that will give you a complacency. You should not be complacent about the scar, isn't it, Vinayendran? So I think that's enough for this case.
Now we'll move on to the next case.
Yes.
G2A1, 25 years at 26 weeks, 2 days gestation, conceived after ovulation induction. Past obstetric history, encirculated and at 14 weeks, history indicated. Triplet pregnancy conceived by ovulation induction 1 year back, history of chorioamnionitis following vaginitis, cervical incompetence at 18 weeks, spontaneous expulsion of fetus. History of suction and evacuation done. No antenatal complications or comorbidities. Referred from another hospital after 1 day of admission there. Presented with the complaints of lower abdominal pain, vomiting, myalgia. At the outside hospital, patient was put on supportive medications, tocolytics and betnosol prophylaxis was given. Patient was conscious and oriented, BP 130/70, pulse rate 110 per minute, history of sinus tachycardia since childhood, evaluated, echo done, was within normal limits. SpO2 99% under room air. Chest clear, CVS S1 S2 normal, CNS no focal neurological deficit. Abdomen mild gaseous distension, tenderness in the right upper quadrant of abdomen. Uterus corresponds to gestational age, relaxed, appreciating fetal movements well. FHR 140 per minute, regular in rhythm. Ultrasound showed mild ascites, mild pleural effusion, maximum depth 3 to 4 millimeter. Single live intrauterine pregnancy, 27 weeks, 5 days. AFI 13.7, estimated fetal weight 1068 grams. Excessive bowel gas shadow, no obvious dilate blood bowel. Sorry. Investigations on day of admission, hemoglobin was 9.8, total count 18,700, CRP 12, LFT, RFT with the normal limits. Patient had on and off episodes of epigastric pain and vomiting. Gastromedicine and gastrosurgery consultation was sought and the orders were carried out. Serum amylase, lipase with the normal limits, anti-HCV, IgM, HbS, Ag were all negative. In view of persistent gastrointestinal symptoms, MRI abdomen and
Hello, Kekamala.
pelvis was done. Features of multiple over the period in the hospital stay, patient had asymptomatic periods lasting 4 to 5 days, followed by aggravation of symptoms, which were all managed conservatively as per gastrosurgery and gastromedicine advice. 9th day of admission at 27 weeks, 3 days, patient for diagnostic laparoscopy in view of persistent on and off symptoms of abdominal pain and vomiting. Patient and bystanders not willing. Repeat investigations on 10th day of admission. Hemoglobin, there was slight fall 8.3, TC 12,900, CRP elevated 92, SGOT, SGPT was slightly elevated 145 and 146, RFT normal. On 12th day, HB 8.7, CRP 31, SGOT-PT still elevating to 94 and 312. Total bilirubin 2.5. On 15th day of admission at 4:30 a.m., patient complained of bleeding per vaginum and was not appreciating fetal movements. On examination, FHR could not be appreciated. Emergency ultrasound confirmed intrauterine demise, 29 weeks, 3 days. Placenta posterior low-lying covering the os, few retroplacental clots, AFI 12.7. Cervical length 3.3 centimeter, U-shaped funneling, encerclage in situ. estimated fetal weight 1.433 kg, screening of maternal abdomen, moderate ascites, bilateral pleural effusion. Patient had altered consciousness, pallor present, BP 80-50, pulse rate 136 per minute, SpO2 99 under room air, respiratory rate 30, chest clear, bilateral basal crepitations present, CVS S1 S2 normally heard, per abdomen uterus was tense and tender, perspective examination, clots present. Patient was catheterized with initial urine output 100 ml. Hourly urine output was less than 10 ml. Patient was started on IV crystalloids, 1 pint PRBC transfused, taken up for emergency laparotomy after stabilizing the patient. Intraoperatively, patient was transfused 1 pint PRBC in view of intraoperative blood loss. Vertical incision, peritoneal cavity contained plenty of blood and blood clots, removed approximately 1000 ml of blood clots. Uterus was cochlear and with a blackish discoloration, defect in the fundus at the attachment of placenta. Products of conception with intact sac was on the verge of expulsion due to extreme softness of uterus. Baby removed by rupturing the sac. Female dead baby of birth weight 1.29 kg, delivered at 8:25 a.m. Placenta and membranes removed from the uterus and peritoneal cavity. Bowel was adherent to the fundus of the uterus. Os was closed. A case shown to gastrosurgeon, exploration of abdominal cavity done. Bleeding points at the site of placental placement in the side walls and mesentery of small intestine cauterized. Complete hemostasis attained under surface of the liver and spleen layers. Os was closed, drain put on the left side. Intraoperatively, transfused with 1 PRBC. Post-op 2 pint PRBC was transfused and 1 pint FFP given. Patient's vitals were stable. Meropenem and metrogel given post-operatively. Intraperitoneal drain put and was removed on POD 8. Patient was discharged on POD 9. 15th day, post-operative day 1, hemoglobin 9.3, SGOT PT 325 and 407, RFT normal. On 13th post-op day, SGOT and PT showed decrease in tendency and urea RFT was normal. Post-operative patient vital stable. In the post-operative period, POD 1, patient had elevated systolic diastolic BP 146/104 millimeter of Hg. Lebitilol was tab lebitilol 100 milligram was given and BP was under 140/90 after that episode. pH profile within normal limits. Antibiotics given post-operatively were meropenem and metrogel. Intraperitoneal drain output subsequently decreased over the post-operative days and was removed on day 8. Patient was clinically and symptomatically better and was discharged on POD 9. I invite Radhamani Madam for the discussion.
Okay, thank you, Mini. And we start from the beginning. See whether there is a risk factor for a rupture in this patient. From the history of this patient, her previous pregnancy, 18 weeks, this triplet pregnancy, she had an abortion. That was following a chorioamnionitis and she had a cervical incompetence, it is said like that. And expelled the fetus and suction evacuation done. 18 weeks triplet pregnancy, usually uterus may be more bigger in size. And when there is an associated infection also, the more chance of producing some injury to the uterus. It may not be a full-fledged perforation of uterus. It may be some weakness so that they have been produced on the myometrium. Maybe because if the patient was stable, it would have gone undiagnosed. And asymptomatic cases can also occur because it may not be a complete rupture. But when there is chorioamnionitis, there is increased risk of the placenta getting adherent also. When this adherent placenta is removed by suction, more chance of producing injury to the myometrium. That we should keep in mind. This background history we have to keep in mind when this patient is, we are going to discuss this patient. And she was admitted with abdominal pain, myalgia, and vomiting, etc. Mainly upper abdominal discomfort. Think of some gastroenterous problems, and she was observed. And she had only myogaseous digestion. Otherwise, it was almost normal. Therefore, we did not think of an acute condition there. But the ultrasonography has shown that mild ascites. why should this patient at this 26-7 weeks of pregnancy should have a mild ascites? Usually, if there is an ascites, and you have to think whether there is any infection or any cyst rupture or any leakage or something like that. And how you find out whether it is a clear fluid or blood or pus is that by finding the pattern or the appearance of the fluid. If it is a clear fluid, okay, maybe ascites. But if there is internal echoes, it may be suggestive of either blood or it may be some infection may also be there. And they have written a single live intrauterine pregnancy, 27 weeks, 5 days, that is it, and excessive bowel gas. And the myometrium, when this patient is having, you have to look at the myometrium also, even though at that point we are not suspecting any rupture at that point of time. But in this patient, you have to have a complete evaluation of other viscera also, like liver, pancreas, gallbladder, etc. Whether there is any pancreatitis, especially when the patient is complaining upper abdominal pain and ascites, there have to think of all these other conditions also. And look at the fluid, whether it is increasing or not. If there is an increase in the nature of the increase in the fluid amount, or if there is any internal echoes, it's possible under ultrasound guidance, you can do a diagnostic aspiration and see whether it is a clear fluid, whether it is a blood, or whether it is an pus. But that is some controversial, but I think that if you can do that, you can find out the nature of the fluid. If it comes out to be blood, then you have to think very seriously about this patient. And at the time of admission, her CRP was 12.12, otherwise it was normal. TC was 18,700. And I think that she was seen by medical gastro, cervical gastro, serum amylase, lipase, everything was normal. And MRI has been done for this patient. I don't know which date the MRI has been and how many days after admission. MRI has been done, shows moderate ascites and a bilateral pleural effusion. Now, MRA is, when you do an MRA is superior for soft tissue delineation resolution, and you'll be able to find out the uterine myometrium, whole thickness of uterine myometrium, especially the nature of the fluid. MRA will give you specific characteristics of the fluid if it is blood, because the presence of blood products like deoxyhemoglobin, methemoglobin, etc. Therefore, a radiologist will be able to give you an opinion regarding the nature of the fluid. And the MRA just written that there is moderate ascites, mild pleural effusion, etc. That indication, anything has been written about the other viscera in the abdominal cavity, the myometrium, or the ovaries, etc. It is you have to find it out. And in these cases, if you are doing such cases, and in this clinical scenario, you can discuss the radiologist. We can give a picture about the clinical situation of the patient, and the radiologist should be give more importance to the findings, and they will be able to give an. Otherwise, there is no purpose of doing an MRI. Ultrasonography also mild ascites. This also has written as mild to moderate ascites. But what other information we have gained from this doing an MRI? Therefore, in these cases, the clinician obstetrician should discuss the case with the radiologist and have an opinion regarding the need of MRI, because we are going to take a decision on the findings. Probably you may be able to find out some weakness or some thinning of the myometrium or other features may be there. And then the patient was followed up, because the problem here is that this patient did not go in for an acute condition. She was in an indolent phase, that is lasting for a long time. Or sometimes she is asymptomatic. Therefore, we cannot blame anybody, because we also will do that. So patient is asymptomatic, remain asymptomatic, we just observe the patient, that is all. And she was suggested laparoscopy, but they were not willing at that time. And then you see that the investigation, from the 10th day onwards, it has shown an increase in the LFT, that is the SGOT, SGPT, serum bilirubin. Whether it has been evaluated, what was the opinion of the medical gastroenterologist, surgical gastroenterologist about this? Bilirubin is also increasing, but her viral markers were normal. And going back on the first post-operative day, she had a mild elevation of the blood pressure also. And when the LFT is increasing, the platelet count and LDH has not been done. Therefore, we cannot say whether it was a negative. It will help or like that. That also we have to keep in mind. Had to give importance to a drastic increase in the SDOT, SDPT. From 16, it has gone to 145. From there, it is 295. It's a progressive increase in the liver enzymes. This should be also evaluated. And what was the opinion of the gastron? That I would like to know about that. Or whether she was given any treatment for that also. And on 15th day after admission, that is, she was admitted 26th. On 15th day of the admission, all on a sudden there is a severe pain and the bleeding PV. Previous ultrasonography has written that the placenta is in the posterior wall. Whether it is upper or lower segment is not written. But when the patient had the bleeding and sudden bout of bleeding and not appreciable fetal movements, and her BP fall was there, and per speculum examination clots present. And ultrasonography has now shown that the placenta is in the lower segment covering the os. I still doubt which we have to rely, which scan we have to rely. Where is the placenta? Actually, this is completely a controversial case. Where is the placenta actually located? Whether it is in the lower uterine segment covering the os, or it is upper segment. What is the reason for the bleeding? And if it was actually in the lower uterine segment, the bleeding can be explained by the presence of the placenta covering the os. And otherwise, whether it was an abrasion also, because they have written as some retroplacental clot is also there. Pure retroplacental clot. And moderate ascites, violent pleural and FH was absent. And actually, what is the situation the placenta had to see? And then because there was a moderate fluid and the patient was in shock, they had taken up for emergency laparotomy. And again, at the time of, because she was given blood transfusion also, and she was taken for emergency laparotomy, the laparotomy findings also, peritoneal cavity contained plenty of blood and blood clots. Removed almost 1,000 ml of clots. 1,000 ml means 1,000 clots means 1,000 ml of blood. Therefore, that shows that there is a severe intraperitoneal hemorrhage has occurred. And probably this intraperitoneal hemorrhage and the patient going into shock may explain the absence of the fetal heart. The fetal movement, fetal heart is absent. May explain. And the other finding is a cubular uterus with a blackish discoloration. Cubular uterus nature means that usually we say that cubular uterus is in abrasion. Here, other features of abrasion, whether there is another features of abrasion and is there or not, or whether the black discoloration is at the time where the rent of the uterus has occurred. Even when there is a rent in the uterus, blood can sometimes escape into the, because that is what you see when you are having a ruptured uterus in obstetrical labor. You see the lower uterine segment may be bluish or a hematoma may be there, whether it is due to that or not. And the placenta, the products of concepts, that is with intact membranes are on the verge of expulsion. That shows that whether there is a uterine myometrium covering it was there or not, whether it is the membrane that is covering that, we don't know. Or the peritoneum only is covering, or whether there is any bleeding from the uterine surface. Any active bleeding was there or not. It should be there because otherwise this much of blood cannot come into the peritoneal cavity. And another point written is the placenta and membranes removed from the uterus and peritoneal cavity. I have some confusion regarding that. From the uterus, whether was the placenta actually, whether the placenta was in the uterine cavity, and if it is in the uterine cavity, whether it was actually placenta previa, or whether it was retroplacental clot, what was the nature of the liquor, whether it is a blood stained or not. That is one point. And when it is removed from the peritoneal cavity, so some part of the placenta would have been adherent in the peritoneal cavity somewhere. That shows that maybe there may be a previous some exclusion in the placental tissue. I don't know what because all these points that is written is something confusing. And bowel, another point that is noted is bowel adherent to the fundus of the uterus. This is a very important point. Why should the bowel get adherent to fundus of the uterus? In a normal patient, bowel should not be. Which part of the bowel? That is unfrozen. And if it is a fresh addition of the bowel to uterus, it may be because of the slow or a rupture that has occurred, a subacute case of rupture which has occurred, which has produced the addition of the bowel to the uterus. In previous days, we used to get a old ectopic where rupture of the ectopic tubal abortion occurs, which you call as the old ectopic. There you see when you open the abdomen after 2 weeks or 3 weeks, you see that bowel, and everything will be adherent there. Similarly, whether the addition is due to that or not, or if it is a old addition, thick addition, probably it may be due to a previous injury that would have occurred to the myometrium. All these things we have to keep in mind. And then that is the another point. And therefore the the baby was delivered. It was a dead baby. Dead baby, and placenta is also removed. And after that, there were some bleeding points from the intestine, mesentery, etc. And the side pelvis and the side walls of the peritoneum. That is where was the bleeding point. It was cauterized. That shows that there is something has happened earlier than this acute episode of rupture. It may be a subacute or a slower process of rupture that has occurred in this patient. And uterus at the fundus is the rent was there and closed in 3 layers, and also was closed and drained. Therefore, these are the points from the history and from the laparotomy findings and ultrasound findings. We have to need more clarification. Otherwise, my first impression is that it is a case of rupture which has occurred gradually subacute presentation. That is why we missed this rupture. If it had an acute episode and like the previous case, definitely would have diagnosed it earlier. And that has led to all the problems for this patient. And if you had diagnosed it earlier, could have done a laparotomy, and the baby, 2 weeks the baby was with us, and the baby, we lost the baby also. And what I have to tell in this patient is that in such cases, when the history of any uterine intervention has been there in the previous pregnancy, when these patients come with this typical atypical clinical manifestations, and when you do an ultrasonography, there is fluid in the peritoneal cavity, that too is gradually increasing. Always should have a low threshold for diagnosing an incomplete or a rupture of the uterus in these patients with this background history. And if you discuss these patients with their radiologist, probably they may be able to help you in making a definite diagnosis of. They may give you an idea about whether there is a possibility of it or not. And this patient, and she had a LFT altered, but the platelet and the LDH has not been done. Whether there is an element of separate from this rupture or the abrasion, there is an element of help is also there we have to think of. Jaundice, bilirubin is also elevated. Therefore, could have been avoided if we had suspected it earlier. But anyway, she was observed in the probably in the labor room or in the ward carefully. It is not the fault of this the clinical picture presentation the patient was misguiding. Then she was in between, she was okay. Therefore, nobody will think of such a the complication in this patient.
Thank you, madam.
Discharged on a POD 9. Okay. Now she has got the chance of her having rupture in the subsequent pregnancy is also high, will be high. There should be monitor this patient subsequent pregnancies.
Thank you, Radhamani madam, for madam has elaborated it extensively. Now I invite Prasanna madam for the concluding remarks. Due to lack of time, we will come back to the other experts later.
Damani has clearly depicted the history and findings, and I should say that this patient's imaging did not help in diagnosis. So it's very unfortunate. And from the history, we should suspect that and the history and the examination finding. Why should there be ascites? And it should not be, if you know ultrasound, you need not say you you can definitely say whether it is blood or fluid in the peritoneal cavity. Blood has a very typical appearance. And pus has almost similar, but we can make out whether it is pus or not. So we should, because of the fluid in the peritoneal cavity, we should have suspected this low rupture and the symptoms also, intermittent symptoms. That with that symptom also, we should have suspected that she may be leaking. And the bowel distension, when there is blood in the peritoneal cavity, bowel will distend, greatly distant. And it's difficult to diagnose, percuss out the fluid when there is so much of bowel distension also. And this patient's bowel adhesion may be because of this slow rupture. And the rupture may be from a weak point in the previous evacuation. So previous evacuation may not have ruptured, but there might have been a weak point. I still remember one patient who had a missed abortion evacuation. She came with some spotting PV, pain abdomen, and in ultrasound and showed that there is a huge, somewhat 5-6 centimeter hematoma in the myometrium. I did laparoscopy and it confirmed, and then that was repaired. But in the subsequent pregnancy, she didn't go for rupture. This car was okay, and we got the baby. So it can occur. It can occur, as Dr. Adamani rightly pointed out, following an evacuation, especially when there is infection. There is chance for weak points in the myometrium. Sometimes it may perforate at that point itself, or the perforation may be missed, and later on she can go in for all these complications. And this bowel adhesion maybe because of the intermittent escape of blood through the myometrium, through the rupture, slow rupture, intermittently the blood escaping, and the bowel getting adherent, and that's why they have coagulated some points in the bowel mesentery. And bilirubin increase can occur because of the excess blood from the peritoneal cavity getting absorbed. Bilirubin can increase. And this patient later on had high BP also. So this liver enzyme could be part of her PIH also. Platelet and LDH we don't have, as Radhamani has already said. So these are all the points I noted. Imaging, if you want to make use of imaging, you should do the ultrasound yourself. See, if you done a proper ultrasound, we could have made out that she's leaking, and because the fluid is increasing with the fluid in blood, we have to suspect that it could be a rupture and blood escaping from the uterus into the peritoneal cavity. And an early interference could have saved the fetus also. Fetus was alive. 27 weeks is nowadays viable, no? And we have to always suspect that. And we should, this patient's imaging didn't help. MRI was no help at all. MRI, they should, as it has been already pointed out, we should tell the radiologist that we are suspecting some defect in the myometrium. You have to look for that myometrium. And actually, you can go through the MRI images. They will give the images. We can go through the image, and even if they don't report, somebody from some other country may be reporting the MRI. So if you yourself go through the MRI image, we can make out that there may be a defect. We usually go through all the MRI images if there is something like confusing like this. We can go through the images and make out whether there is a weak point or not, whether she is bleeding from there or is coming out through the myometrium. So we have to go through the images ourselves, or actually we should diagnose by ultrasound. If that is not that was not done in this patient, but a laparoscopy would have had the answer. but the patient didn't agree for laparoscopy. Laparoscopy, unless it is without blood, let's say rupture in the posterior lower aspect of the pregnant uterus, laparoscopy may not be able to diagnose, but otherwise we'll be able to, this patient's fundal region and the bowel adherent, etc., etc. A laparoscopy could have easily diagnosed it, and an early interference could have saved the baby also. And the next time also she is likely to go for rupture, so we should be very careful in managing the next pregnancy. You should tell the patient and the relatives, and legibly write in the discharge card. So one lesson is imaging ultrasound. Every obstetrician should know how to do an ultrasound. How to make out whether it is blood or fluid or pus, or what is the placenta, where is the placenta, what is the baby like, everything. It is all very easy, and it's not very difficult at all. So all obstetricians should learn how to make it out, and a proper history taking. This patient's imaging actually didn't help her at all, help in management at all, and even the MRI. So we have to go through the MRI imaging. If you see the image, we can make out that there is some abnormality in the image. So if the report, even if the report is otherwise, we have to convince ourselves by going through the images. And bilirubin increase can occur because of the blood getting absorbed from the peritoneal cavity. Bilirubin can increase. We have seen old ectopic patients coming in jaundice, and intermittent symptom because of the intermittent bleeding. And this patient might have had preeclampsia also. She had high BP after the surgery. Maybe liver enzyme as part of the. And another thing is she might have been given high dose of progesterones, which can also cause increase in liver enzymes, which came down drastically after delivery. So there are so many learning points in this. I think I will conclude with that.
Thank you, Prasanna Madam. Move on to next case. 25-year-old second gravida, previous LSCS, 18 months back, gestational age 36 weeks, referred from local hospital with a non-localized fetal heart. History of pain abdomen the previous day, for which she consulted the doctor but was sent home with analgesics. Examination revealed normal vitals. Palpation revealed non-tense, non-tender uterus with an unidentifiable abdominal contour. Fetal parts felt. Non-localized FHS on auscultation. Ultrasound showed fetus in breech presentation, absent fetal cardiac activity, fluid in the peritoneal hepatorenal pouch, placenta separated with retroperitoneal clots. An emergency laparotomy was performed. Fresh intrauterine fetal demise. Male baby weighing 2.71 kg was delivered in breech presentation. Placenta was found fully separated in the peritoneal cavity behind the approximately 20-week size uterus, which was impacted on the left side. Full-length scar rupture with lateral extension involving the right uterine artery. About 1.25 liters of blood and clots were found in the peritoneal cavity. Uterine artery ligation done. Ruptured uterus was sutured in layers. So I invite Sridevi Madam for expert opinion.
I didn't get all the points. I couldn't hear you properly.
Sorry, Madam. Once more, I will present. Now, can you hear me, Madam?
Now I can hear you.
So 25-year-old second gravida, previous years, 18 months back, presented at 36 weeks. She was referred from local hospital with non-localized fetal heart. History of pain abdomen previous day, for which she consulted the doctor but was sent home with analgesics. Examination revealed vitals normal. Palpation revealed non-tense, non-tender uterus with an unidentifiable abdominal contour. Fetal parts felt. Non-FHS not localized. Ultrasound showed fetus in breech presentation. Fetal cardiac activity absent. Fluid in hepatorenal pouch. Placenta separated with the retroplacental clots. Emergency laparotomy performed. Fresh intrauterine fetal demise. Male baby 2.71 kg delivered in breech presentation. Placenta was found fully separated in the peritoneal cavity behind the approximately 20-week size uterus, which was impacted on the left side. Full length scar rupture with lateral extension involving the right uterine artery. About 1.25 liters of blood and clots were found in the peritoneal cavity. Uterine artery ligation done. Rupture uterus sutured in layers.
So this was a 25-year-old second gravida, 36 weeks, no?
Yes,
And
madam.
it was a referred case. It was a referred case. And she complained of her pain abdomen. Pain abdomen, only one day. The previous day she started having the pain abdomen. And on examination, you said the vitals were stable.
Stable. Yeah.
Stable.
Yes, ma'am.
And on palpation, there was uterine tenderness.
Yes.
Was it so? Uterine tenderness. And fetal heart was not present. Fetal parts were palpable. And on examination,
Uterus was
further
non-tense, non-tender with
non-tense, non-tense.
uterine contour
Okay.
was not identifiable. Fetal parts felt.
Felt. So
Yeah.
with this findings, what do you think it as a case of? As a
Rupture.
case of rupture uterus. What could be the reason for the rupture in this case? Can you give that point?
Maybe
Why? Why?
She
Could
was
be.
complaining of pain the previous day, maybe mild
But
contraction.
What is the cause for rupture in this case? What do you think?
Antenatal rupture, not intrapartum, previous cesarean, lower segment.
I know that it is lower segment, intrapart, not she is not in labor.
Not in labor, madam.
So what could be the reason for the rupture?
Madam, previous
For
LSCS ആയിരുന്നു
previous
madam.
years, sir.
അതെ അത് പറയണ്ടേ ആൻസർ കിട്ടാൻ വേണ്ടിയാ ഞാൻ കാത്തിരുന്നത്.
Previous years, madam.
Previous cesarean section.
Yes.
And placenta was
Separated and lying in the abdominal cavity, peritoneal cavity.
peritoneal cavity. The reason for the rupture, how can you explain the rupture? Reason for the rupture. What could have been? Rupture is
She did,
because
madam.
yes, what is it?
Maybe
Lakshmi?
ഇല്ല മാഡം ഇല്ല, ഞാൻ സമയം പറഞ്ഞതാ മാഡം.
Okay, short. It is a full length scar rupture.
Yes, madam. Maybe due to poor
Why?
quality of scar.
Poor quality of scar. Quality means?
Maybe thin.
Maybe.
Inter-delivery interval was only 18 months. Short interval of
18.
Yeah.
Okay. Then can you find any other reason for the weak scar? Any reason, one point, just because of the time constraints.
In this
Otherwise,
case,
Lakshmi Amma,
not much, not other factors are not mentioned, madam.
but you have to say the factors if it is not mentioned.
Maybe previous infection.
Could you find any reason?
Madam?
Any infection? Yes.
Suturing in
Proper?
single layer. Proper closure.
Proper closure of the uterine layers.
Incision during the previous
Some
section.
people close a single layer closure. Is there any problem with a single layer closure?
Approximation is not correct. The scar
May
maybe
not be
will
proper.
become.
May not be proper. Okay. If
become,
time limit is there, I think I will stop here, Lakshmi.
Yeah. Okay.
Any other point to be added? No. Anybody has got any points to be added to this case?
Hello, Sridevi?
Previous day
Yes.
with pain, no. So she should
Hello?
have
Yes.
been properly examined. They might
Yes.
have been scarredness, and she should not be left alone with analgesic.
Yeah, she should
Yes.
not have been admitted.
എനിക്ക് കുറെ points
Subordinate.
കേൾക്കാൻ വയ്യായിരുന്നു. I couldn't get the whole story. Okay.
മാഡം
So that
മാഡത്തിന്
was
അയച്ചു തന്ന
yes.
കേസാണ് മാഡം അത്.
അതെ, ഞാനത്
ശ്രീദേവി
മുഴുവൻ
മാഡത്തിന്
എനിക്ക്
ഓൾറെഡി
കണ്ടില്ല.
അയച്ചു തന്നിട്ടുണ്ട് ആ കേസ്.
അതെ, അത് മുഴുവൻ കണ്ടില്ല അതല്ലേ.
ഏ
Not because of my fault. പറഞ്ഞോ, കുഴപ്പമില്ല. You discuss. I will also join. That is all.
പ്രസന്ന മാഡം then you discuss മാഡം. ശ്രീദേവി മാഡം
Yeah.
ജോയിൻ ചെയ്യാന്ന് പറഞ്ഞു.
I'll join. Okay.
Because this is a previous Syrian patient who came the previous day with pain abdomen. She should have been properly examined. The proper history might
Proper
have been
examination, very
taken,
important.
and there might have been scar tenderness, and she could have been taken for surgery at that point
Immediate
itself.
surgery.
And another thing is the integrity of the scar. I've seen so many obstetricians putting in a higher up transverse incision. That can easily give way in labor. So it should be, when you put an incision, it should be in the middle of the lower segment. It should not be a higher up transverse incision, which can go in for rupture the subsequent pregnancy. And it should be in the middle of the lower segment. And when you close, the decidua should be excluded. And ideally should be in 2 layers. And it should not be very tight to produce necrosis. And only tissue approximation should be there. And it should be patronized. So proper closure of the cesarean incision and proper placement of the incision also is very important. It should not be a higher up transverse incision. I have seen so many people putting a higher up transverse incision. It can give way in the subsequent pregnancy. It should be ideally in the lower segment itself. And it should be, and lower segment should be identified after opening the abdomen by the loose fold of peritoneum. And if it is 2.5 centimeter, you put the middle of the 2.5. If it is 5 centimeter, you put the incision in the middle of the 5 centimeter. In the second stage cesarean, it may be some 5 or 10 centimeters. There also you find out the middle and put the incision. Otherwise, your incision can go down and extend and involve the parametrium and the ureter. So always put the incision in the middle of the lower segment, and always exclude the cause necrosis of the tissue. It should not be too tight. It should be just for approximation. And if she had a puerperal fever, it should be mentioned in the discharge card. She'll be taken for an elective cesarean before time. Okay.
And peritoneal closure also is important. Some people just keep it, the peritoneum which is opened, that is transversely, they keep it there without closing. That is also there.
Both peritoneum
That
should
is
be closed.
Lower.
Thank you, madam.
What is next, Lakshmi?
Short
Right.
presentation on near miss cases.
Okay.
Patient referred from local hospital in view of hemoglobin fall from 10.5 to 7.4 with complaints of acute abdominal pain. 35-year-old second gravida, previous CS at 13 weeks 4 days gestation. At casualty, patient had one episode of uprolling of eye and staring for lasting for 3 to 5 seconds. No complaints of frothing or involuntary jerk managed with injection levetiracetam 500 milligram IV. On examination, pallor was present, BP 80-60, pulse rate 110 per minute, abdomen was distended with a tenderness, previous CS scar site tenderness present. Ultrasound showed fluid in the hepatorenal pouch and pelvis. Uterus contour seen, live pregnancy seen in the lower part of uterine cavity, upper part of uterus distended. Patient then diagnosed to have scar pregnancy rupture with placenta percreta with hemoperitoneum in shock. Patient underwent emergency laparotomy under GA. Peritoneal cavity contained 2.1 liter of blood and 320 gram of clots. Lower part of the uterus distended with gestational sac and placenta protruding through the scar site. Hematoma was present over the lower uterine segment. Bilateral tubes and ovaries normal. Proceeded with the removal of scar pregnancy. Bilateral uterine artery ligation done. Total blood loss 3 liter. 3-point PRBC, 3-point FFP, 5-point platelet transfused intraoperatively. Postoperatively, 1 unit PRBC transfused. Peritoneal drain inserted. Inviting Radhavani Madam for discussion.
So this is a straightforward case of cesarean scar pregnancy. And when you classify it as a type 3 or exogenous type of cesarean scar pregnancy. And unfortunately, it was diagnosed at 13 weeks, 4 days. And with a presentation, acute presentation with intraperitoneal hemorrhage and hemodynamic instability. Therefore, it is a late diagnosis and she needed laparotomy and excision with cesarean scar pregnancy and transfusion, multiple transfusion also. And if it has been diagnosed early, this acute intervention or the emergency could have been avoided. Therefore, in all cases, it is mandatory that you should do an ultrasonography early in pregnancy in all cases of LSCS. That is, all bodies recommend that. And ideal time, because 45% of cases of cesarean scar pregnancy in early stages may be asymptomatic. And to produce symptoms, they may advance further and then it may be an acute situation. And you can diagnose it as early as 6 weeks. Ideal time is to do an ultrasonography between 6 to 8 or 9 weeks, but not later than 9 weeks, because after the 9 weeks, what will happen is that the gestational sac will go into the uterine cavity. But if it is a scar pregnancy or a pregnancy in the niche, the placental site will be there. That will be helping us to make a diagnosis of it. And you do a transferring ultrasonography with a half full bladder. That is the ideal method. And what you look for is the site of the gestational sac. If the gestational sac is in the lower part of the uterine cavity, you have to find whether it is related to the uterine scar, that is, whether it is in the scar or whether it's already a niche is there. And if a niche is there and implantation occurring into the niche, that is the one which is associated with the high risk of placenta accreta spectrum later. Therefore, early scan is important. Therefore, first you look at the site of the gestational sac. And depending upon the type, we can say that it's an exogenous or endogenous. There are so many classifications based on the ultrasonography, grade 1, grade 2, grade 3, etc. Therefore, classify the cesarean scar pregnancy. And along with that, you can find a trophoblastic layer also and see the vascularity. Very, very important to do a Doppler velocimetry. But if there is a high velocity, there is P-systolic velocimetries that shows it is highly vascular, and they are at risk of developing rupture, intraperitoneal hemorrhage, etc. Therefore, do a localization of the gestational sac, classify it as a class, the cesarean scar pregnancy or pregnancies in the niche, find out the vascularity of this patient, and always see that there is a uterine cavities also. Look at the uterine because there can be heterotopic pregnancy also. If you diagnose it early, what we can do is we can do the intervention can be done early, either medical treatment or surgical treatment. Yeah, that depends upon the type of the cesarean scar pregnancy, beta SCG value, the Doppler velocimetry, hemodynamic stability, and also whether the expertization for endoscopy surgery or intervention radiology facilities are there. Therefore, the medical management if you diagnose early is methotrexate, but systemic methotrexate alone is not recommended, or methotrexate along with uterine artery embolization or evacuation, or we can have a local methotrexate and aspiration is necessary, but in these cases need a continuous follow for a long time. Then uterine artery embolization along with the systemic methotrexate or surgical evacuation, either hysteroscope. If it is an endogenous type and the type 1, in those cases you can have an hysteroscopic evacuation can be done. But if it is towards this, that is the exogenous type or type 2 or type 3, in those cases, you might do a laparoscopy and the excision can be done. Then chemoembolization is another method by which we can treat this early ectopic gestation. But medical management is only for cesarean scar pregnancy less than 7 weeks and beta C less than 5,000 and residual myomer thickness is there at least 5 millimeters. And hysteroscopy or laparoscopy depending upon the type of the type of the cesarean scar pregnancy. The advantage of doing a surgical intervention is that you can repair the scar so that you can prevent the subsequent cesarean scar pregnancy. And in these cases, when you're doing an laparoscopy, but if you diagnose it early, advantage is that you can make it with elective procedure with every setup and efficient endoscopy surgeon. And you can do it as an elective procedure, unlike this case where patient has come in shock, the rupture already has occurred, and therefore you have to do a laparotomy for this patient. Therefore, early diagnosis will help you less invasive procedures. When you get laparoscopic and excision, you can do a bilateral uterine artery ligation or clipping. The clipping of the uterine artery can be done to or local vasopressor injection to reduce the bleeding. And another new method of treatment that is coming in the management of cesarean pregnancy is high intensity focused ultrasound therapy. And not alone that, along with that, you can do suction ureter under hysteroscopic guidance or ultrasound therapy. That is a very safe and effective method for very early cases of cesarean pregnancy. Therefore, this patient, I don't know whether this patient had an ultrasonography early done, whether it was diagnosed early and or it is the first time that she's having an presentation and an ultrasonography. Therefore, all cases is mandatory. All guidelines say that in cases of previous cesarean, because of the increased incidence of cesarean scar pregnancy, it is better to do an ultrasonography, that do a ultrasonography quite early in pregnancy, as early as possible, even less than 9 weeks of pregnancy. But later, if you do it, you can identify this placenta location, etc., and predict a placenta accreta spectrum later.
Yes,
Prasanna
madam. Lakshmi Ammal, this patient had hypoxia and convulsion. There is no need for Levipil. Because of the hypoxia, she went in for convulsion.
Can occur because of hypoxia.
Any patient having any convulsive episode, they'll give Levipil. What are the reason? It is because of the hypotension, hypoxia, stress, gone this uprolling of the eyes.
Yeah.
And that you and all even vasovagal symptoms patients can have. Attacks.
So there is no question of Levipil for that
There
patient.
no need of in this case.
Yeah. As madam said, we will have to do the ultrasound earlier and find out the site of the sac. That is the most important thing. If the sac is lower down, you can even go for termination of that pregnancy by any means, so that you can prevent scar ectopics as well as placenta accreta spectrum later on.
Especially in case of
baby Vinay, scar ectopies can be called as baby PAS.
Yeah.
Yeah.
Baby PAS.
Yeah.
Prasanna madam, you have any additional points? Madam, just we have
what
given
I have to
only.
say is, let me again stress the importance of the ultrasound, doing the obstetrician doing the ultrasound herself. And there is a systematic way of doing the ultrasound. That's very important. Not that it should be done. It should be systematically done. You introduce the probe gently, image the mid-sagittal plane of the uterus. You identify the cervical canal, identify this area of the scar, identify the uterine cavity, the mid-sagittal. And then in the mid-sagittal, if it is scar pregnancy, you can see the pregnancy in the scar. The pregnancy in the scar itself. And when you do the systematic transvaginal scan, identify the mid-sagittal image first. In relation to this patient, I would like to emphasize the systematic way of doing the transvaginal scan. First of all, you do the mid-sagittal image, where you can diagnose cervical pregnancy, scar pregnancy, intrauterine, and then parasagittal, because there may be another sac on the right side or the left side that you can miss if you do it. Put the probe, see the sac, remove the probe. Don't do that. You have to image the mid-sagittal, then the parasagittal, the other parasagittal, and then the both adnexa, and then the axial image. axial. You depress the probe and axial image from the cervix to the fundus. Otherwise, you can miss so many things. That's one thing. And if you can diagnose early, as has been emphasized early by Radhamani, we can do it as an elective procedure. And the advantage of doing a laparoscopic procedure is that we can repair the scar. And it is not, even if it is 10 weeks, you inject vasopressin. We have tackled some 12 laparoscopic scar pregnancies. It didn't bleed at all. We can inject vasopressin, and you should be dissecting the peritoneum in small steps so that you won't injure the bladder. The bladder will be distended over the sac. You can see the bladder covering the sac. So it can be gently dissected after injecting vasopressin, and then you incise the sac, remove the products, and suture. In the initial few cases, we used to put 2 holes in the broad ligament so that if she bleeds, we can put a tourniquet like that. But we never had the occasion to put a tourniquet or think of putting a tourniquet. She never bleeds. So it can be, that is the advantage of doing it laparoscopically. We can suture the scar. And if it is early, we can hysteroscopically remove with type 1 and type 2. Not bulging into the bladder, you can easily hysteroscopically remove. And when you find at 5 weeks, a sac in the lower aspect near the scar, we can put a small hysteroscope, and see whether the implantation is anterior or posterior. If the implantation is posterior, we need not interfere. We need not advise the termination. If it is anterior, of course, we have. Just put the scope and see, that's all. So these are the 2 points which I would like to emphasize.
Madam, another thing, if it is a live pregnancy, you can inject a KCL and then continue with methotrexate so that it will get cured easily.
Unless you repair the scar, the next time also she will go for a scar pregnancy. So
Yes,
if it is
and you can do it transvaginally also. There is no need for laparoscopy. Transvaginal
suturing.
Repair also
we
can
have
be
not done transvaginal suturing.
Especially
we do laparoscopic suturing only.
After methotrexate and then the sac has decreased in size, there is not much of bleeding. You will be able to easily do it by 1 or 2 stitches at that side.
Government medical college, it's possible. Yes. Private setup, you have to tackle that day itself. Otherwise, patient will run to the next door.
Madam, we can go to the next case.
Okay.
Next case is 24-year-old fourth gravida with 3 full-term normal vaginal delivery. Gestational hypertension detected at 37 weeks. Started on tap, cardiac at 10 mg BD. Admitted at 39 weeks. Previous obstetric history. Previous 3 normal delivery, 10 years, 5 years, and last childbirth 3.5 years back. Uneventful. Examination revealed BP of 120/80. Term uterus, fetus in cephalic presentation, good FHS. Pervaginal examination, cervix soft, mid position, 25% effaced, admitting tip of finger, vertex at brim, pelvis adequate, modified Bishop score 3. Induced with mifepristone 200 mg, followed 48 hours later with misoprostol 50 microgram orally. Next day after reassessment, another 25 microgram was given. The next day, PV, cervix soft, mid position, 50% effaced, 2 finger, membranes plus, vertex at -3. And she was started on oxytocin augmentation at 10 a.m. 5 hours later, the contractions were adequate and oxytocin was on flow at 16 drops per minute. Pervaginal examination, at that time, cervix soft, mid position, 75% effaced, 2 finger loose, bag of membrane forming, vertex at -3. ARM done, clear liquor was draining, oxytocin stopped, patient progressed and become fully dilated and effaced with the vertex at +2 in 45 minutes and delivered a live term male baby within 10 minutes with right mediolateral episiotomy. After normal 3rd stage, patient developed excessive bleeding, suspecting atonic PPH, medical management given, no cervical tears were noted, pulse rate rose to 130 per minute, hypertension developed, BP 90, 60 millimeter of Hg, uterus intermittent atonicity, medical management continued, suction cannula was introduced, uterus contracted, vitals, pulse rate 94, BP 160, second point PRBC transfusion given. Sorry.
That's a case.
That's it.
I think
Yes.
we'll ask Dr.
and
Vinay Chandran sir and then
sir.
go to the other case.
Yes.
Mini, what was the indication for this patient?
She was a
Gestational
Gestation-
hypertension patient detected at 37 weeks on antihypertensives and induced at 39 weeks.
BP not mentioned.
BP 120/80, madam. BP 120/80.
Before starting.
BP control. BP is well control, no?
No,
Madam,
before
37 weeks
starting-
kandu antihypertensives koduthu controlled ആയിരുന്നു 39 weeks induce
Control.
ചെയ്തു.
38 weeks induced.
39 weeks.
39 weeks.
So, with the PPH, you said the cervix was intact.
cervix was intact.
There was no
There
tear.
was intermittent atonicity.
Atonicity.
Medical management and suction cannula was inserted. After second bout of bleeding, she hypertension developed. decided
Since
for-
it is a multigravida, when the uterus is not
I
contracting, there is no resistance. You will have to go in and see what is happening, and you will go for a subtotal hysterectomy and finish it.
Yes.
No, this was a tear. No, this was a tear from the cervix extending to the lower segment, 3 centimeters. Isn't it?
Cervix was normal. it was
Excuse me, madam. I think one slide was missing.
Ah.
In drop findings പറഞ്ഞില്ലല്ലോ.
He was bleeding from the O's and site was not identifiable, and so they took the patient to theater, did laparotomy, and found
Laparotomy
that
was done.
they're extending
so-
into the lower segment for 3
So,
centimeters.
so cervical tear was there. It was extending. The upper limit was not seen.
Ah.
So, the definite
Okay.
indication for going for a laparotomy.
For laparotomy, and hysterectomy was done. So, was the induction justified is the question.
Yes, yes.
Yes.
3 times they delivered, 4th time she will deliver.
Yeah.
Spontaneous labor.
And that too with intact membrane, pitocin was given from morning
Yeah.
till
5 hours.
and without doing ARM, pitocin was given. She could have done ARM. And finally, ARM was done fully dilated and she ruptured. We don't know whether she would not have ruptured if early ARM was done. I don't know. But
Anyway, they got the baby.
management, it should have been ARM and then wait for 2-3 hours and then oxytocin. That is what I
1 or
would
2
like.
hours.
But
And then start
there is
up.
no proteinuria and no organ dysfunction. She need not have been in. That is my opinion about it.
Yes, correct.
Can I
I too agree, madam.
Hello, the patient,
Yes, madam.
she's a
Madam, ഈ
fourth-
പേഷ്യന്റ് മാഡം ഈ
fourth
പേഷ്യന്റിന് cervical tear ഉണ്ടായിരുന്നില്ല മാഡം.
അതല്ല
Cervical
മാഡം
tear
ഇൻ ഡ്രോപ്പ് ഫൈൻഡിങ് ഒരു സ്ലൈഡ് മിസ്സിംഗ് ആയിരുന്നു. ഞാൻ ജസ്റ്റ് ഒന്ന് വായിച്ചോട്ടെ.
No cervical tear for this patient.
ഇൻ
And
ഡ്രോപ്പ്
this-
ഫൈൻഡിങ്, എക്സ്ക്യൂസ് മാഡം.
In this
Ah.
patient, she's a
Yes,
fourth
Vinny.
gravida.
Yes.
Listen, please. This patient is a fourth gravida. She is
Yes.
24-year-old. Her first baby is 10 years. Is it a
Yes.
box or this?
Also,
We can inform the police. That is different. First,
അത് 10 വർഷം മുമ്പ് പോണമായിരുന്നു ബോക്സോ.
First PV finding is 25% effaced, that means tip of the finger. Which multigravida you get this PV finding? A patient who had a cervix 3 times, how can the source be tip of the finger?
whatever it
Maybe
is, she
because-
should not have been induced.
It is. And
Tip
another
of
thing
finger
is
or
Should have
one
been
finger.
left alone.
She
Should
should
Should have
have
been
been
left alone.
That is fourth.
No proteinuria,
fourth
no
level.
organ dysfunction. She should have been
Nothing,
left alone.
no comment.
She delivered 3 times. Fourth time also she will deliver.
And
Without
BP
any interference.
house surgeon might have taken the BP.
സ്റ്റാർട്ട് ചെയ്തേക്കുന്ന 50 മൈക്രോഗ്രാംസ് വെച്ചിട്ടാണ് 50 ഫോർത്ത് ഗ്രാവിഡിക്ക് 50 മൈക്രോഗ്രാംസ് മിസോപ്രോസ്റ്റോൾ ആണ് ആദ്യം കൊടുത്തിരിക്കുന്നത്.
അല്ല ലക്ഷ്മി, സർവീസ് ഫേവറബിൾ ആക്കിയിട്ട് പിന്നെ പിറ്റേ ദിവസം
അതെ.
കൊടുത്തിരിക്കുന്നു ചെയ്യാതെ. എന്തൊക്കെയാ ചെയ്തിരിക്കുന്നത്
Used with oxytocin. Cervix favorable, they have started oxytocin.
ഇന്നത്തെ ലേണിംഗ് പോയിന്റ്സ് മാത്രം ഒന്ന് പറഞ്ഞാൽ മാഡം അടുത്ത കേസിലോട്ട് പോവാം.
So one is unnecessary induction.
we should have waited for
Wait,
induction.
Waited for.
Make the service favorable and then go for induction.
Mechanical induction ഉപയോഗിക്കാമായിരുന്നു.
For terminating pregnancy. If there is proteinuria, if there is any organ dysfunction, you go for. Or just to BP reading is not an indication for induction. And another thing is with intact membrane and favorable cervix, you should not give pitocin. You can do ARM if at all you want to induce. That is a learning point. And if there is a like cervical tear extent not seen, you go open the abdomen and see.
അല്ല ഇതിനകത്ത് cervical tear അല്ലായിരുന്നു
ഇതില്ല.
തോന്നുന്നു മാഡം. ഇതിനകത്ത്
ഇതില്
full lateral
Rao
edge
finding was
uterus
lateral
tear.
wall.
ഫുൾ ലാറ്ററൽ എഡ്ജ് ടയർ ആണ് ഈ പേഷ്യന്റ് വന്നത്. അടുത്ത പേഷ്യന്റ് ആണ് സെർവൈക്കൽ ടയർ വന്നിട്ട് മുകളിലേക്ക് പോയത്. അതോടെ വായിച്ചേക്കും ഇനി.
One minute, Lakshmi. Full lateral wall tear, and then they removed the adnexa, isn't it? They removed the adnexa.
അതെന്തുകൊണ്ടാ ലെഫ്റ്റ് ഇൻഫെന്റിബുലോ പെൽവിക് ലിഗമെന്റിലേക്ക് ഹെമറ്റോമ പോയി.
I wanted to tell something about that. If the infantile, if it extends into the broad ligament and retroperitoneum, it can tear the ovarian vessel. Fortunately, this patient's ovarian vessel was not torn. If that was torn, it would have been more catastrophic. She would have bled profusely from the torn ovarian vessel, which is very difficult to capture. അതിങ്ങനെ അബ്ഡോമിനൽ വാൾ റേസ് ചെയ്ത് മേളിൽ പോയി കിഡ്നിയുടെ അവിടെ പോയി പിടിക്കേണ്ടി വരും. അങ്ങനെ ഒരിക്കൽ ഞാൻ പിടിച്ചിട്ടുണ്ട്. പേഷ്യന്റ് ഭയങ്കരമായിട്ട് ബ്ലീഡ് ചെയ്തിട്ട്. പക്ഷെ ഈ പേഷ്യന്റ് ഫോർച്ചുനേറ്റ്ലി ഷീ മേ നോട്ട് ഹാവ് റപ്ചേർഡ് ഹെർ ovarian vessel, even though it extended into the broad ligament. That is one important point. Where you should not proceed with the hysterectomy. You should go look for the ovarian tear and capture the ovarian vessel. Otherwise, whatever blood you give, it will be lost from the ovarian vessel because it comes directly from the aorta. So that is one important point. Unfortunately, this patient didn't rupture her ovarian vessel.
Prasanna, this patient had a laparotomy. There was a hematoma, the left broad ligament extend the infantile.
Might have gone from the uterine.
Behind the descending colon, extending up to splenic flexure.
It can go up to the diaphragm.
It can go like that. Broad
But
ligament
still
movement.
her ovarian didn't go. That is why she escaped. It can go.
Yes.
Once I opened the abdomen for a 36 week size retroperitoneal mass, which developed following a hysterectomy for placenta previa ingrata. Morning somebody did a hysterectomy and evening monitored in a labor room, and evening found out she is in shock. And examination 36 weeks size retroperitoneal hematoma. Clara's patient. I also went. I did the laparotomy. It was a huge hematoma up to the diaphragm. Okay.
Mini next case.
അടുത്ത കേസ് പ്രസന്റ്. So 25-year-old P3L3 normal delivery, admitted on the previous day with PROM, labor induced with oxytocin, underwent normal labor at 5:47 a.m. Intrapartum period was uneventful. 2 hours after delivery, she developed PPH with passage of clots. On inspection, multiple cervical tears present, same sutured, and referred to higher center and reached higher center after 8 hours of delivery. At higher center, patient conscious, oriented, pulse rate 132, BP 80 systolic, shock index 1.65, respiratory rate 18, SpO2 99%. Per abdomen uterus contracted and retracted, 16 weeks, midline. Vagina was packed with a roller pack, same removed. Vagina inspected, found intact, multiple sutures on the cervix, no active bleeding seen. Bedside ultrasound done, no intraperitoneal bleeding seen. Uterus midline, cavity empty, no free fluid in POD. Vaginal pack kept again, medical measures and antibiotics continued, 2 unit PRBC and 2 FFP transfused. After 3 hours of admission, pulse rate 122, BP 170, per abdomen uterus contracted midline. Local examination, vaginal pack removed, bleeding from cervix, bleeding point could not be identified. Vitals deteriorated, hence posted for exploration under GA. Cervix ballooned up, filled with clots. Left side cervical tear extending up, upper limit of which could not be identified. Decided for emergency laparotomy. There was cervical tear on the left side, extending upwards 3 cm. Proceeded with emergency obstetric hysterectomy. 1 pint PRBC, FFP, and 2 pint platelet concentrate transfused in raw. Total 4 unit PRBC, 3 FFP, and 2 platelet.
I think this also goes to Dr. Vinay Chandran for discussion.
See, whenever you see PPH with cervical tears, you'll have to examine the patient under anesthesia with good light, with good assistant. And then if you are not able to get the upper edge of the tears, you may have to go in for a laparotomy and then do the hysterectomy. Here in this case, you may have to go in for a total hysterectomy because it may be more or less a colporexis.
Yes.
That's number.
Thank you.
ഈ പേഷ്യന്റ് പിന്നെ she had normal delivery, isn't it? Not induced.
Yes, madam.
Okay. So
Normal delivery.
ഈ പേഷ്യന്റിനെ
She came with PROM the previous day. She was
Ah.
induced at that hospital, delivered in the morning. 2 hours later, they identified the PPH, found out
Okay.
cervical tear, sutured it, packed the vagina and referred to a higher center. There they saw there were no other bleeding points at that time. So they packed the vagina,
center also, isn't it?
gave the
There
blood,
was a
but
delay
late
in
2
the
hours
center.
later,
Okay.
vitals deteriorated.
ആക്ച്വലി രണ്ടാമത് വൈറ്റൽസ് ഡിറ്റീറിയേറ്റ് ചെയ്യുന്നതിന് മുമ്പ് തന്നെ അത് കണ്ടുപിടിക്കേണ്ടതായിരുന്നു. പ്രോപ്പർ examination with a good light and good assistant, they would have diagnosed the cervical tear and they would have made out that it is extending up to the lower segment and then open the abdomen. So when to escalate the procedure, it is the most important thing in PPH management, and how fast you do all the steps. That is the most important thing in managing PPH. പിന്നെയും വെച്ചിരുന്ന് പേഷ്യന്റ് ഷോക്കിൽ പോകാതെ അതിന് മുമ്പ് തന്നെ റീസൺ ഫോർ അല്ലെങ്കിൽ തന്നെ ബ്ലീഡിങ് നിൽക്കേണ്ടതായിരുന്നല്ലോ. അപ്പോ
when the patient goes in the shock, she may go in for even DIC. Then you had it.
DIC, then it is so difficult to treat. So it's important to timely diagnose and timely escalate the procedure. ഇനിയും പേഷ്യന്റ് ഉണ്ടോ?
Any next case like madam?
Yes, yes.
27-year-old, second gravida, previous preterm CS for PPROM breach 3 years back, done at 29 weeks and delivered by an inverted T incision.
It's an important case. Okay.
Previous child has developmental delay. History of cervical circulation done at 20 weeks in view of funneling of cervix, noted in anomaly scan. Now at 28 weeks plus 2 days of gestation, she presented with the complaints of diffuse abdominal pain, 1 day duration. And no complaints of bleeding PV, leaking, appreciating FM well. Per abdomen uterus around 32 weeks, relaxed, no contractions or scar tenderness, liker excess, cori polyhydramnios, FHS good. She was admitted and given steroid coverage and neuroprotection. USG was taken. Scar thickness was 4.3 millimeter at the thinnest part. AFI was 25 centimeter. Scar thickness and AFI reassessed on day 2, 4.1 millimeter and 27 centimeter AFI. On the same day night, she was brought to LR with the complaints of diffuse abdominal pain. Vitals were stable. Per abdomen uterus 32 weeks, no contractions or scar tenderness, polyhydramnios plus FHS good. She had temporary relief on analgesics. 1 hour later, she had sudden severe abdominal pain with tachycardia and hypotension. Patient was conscious, oriented, pallor present, pulse rate 110 per minute, BP 60/40, SpO2 98% in room air. Per abdomen, uterine condor, difficult to assess. Tenderness plus FHS could not be localized. After assessing the patient's condition and suspecting uterine rupture, she was taken up for emergency exploratory laparotomy under GA. Findings: uterine rupture noted through the previous inverted T incision extending to the fundus. Edges were irregular. Placenta and dead fetus. Sorry, placenta and dead fetus was lying outside the peritoneal cavity.
Outside the
Lying in the peritoneal
uterus.
cavity. There was hemoperitoneum amounting to about 1.5 to 2 liter. Extravasation of blood into the broad ligament, right broad ligament. Extracted a dead male fetus weighing 1.365 kg. 3 lobes of quadround neck noted. Sridevi, madam.
Yes,
Madam, learning points, please.
in this case, here it is, there is a rupture, no? What may be the reason for this rupture in this case?
The inverted T-shaped incision.
Inverted T-shaped incision. Why an inverted T-shaped incision was put? Can you explain that?
It was preterm CS with a lower
All
segment may not be well formed.
It was done at what gestation age? Can you mention that? Do you know that? Previous cesarean?
It was done at
previous
29
week?
weeks, madam. 29 weeks.
Yes. So it could have been an inverted T incision. But always you need an inverted T incision in such cases.
Most probably they might have gone for inverted T because the head might have been caught inside. It was a breach.
Pardon?
No, whatever it is,
Maybe
you
because
are not supposed to put an inverted T incision.
Yeah.
inverted
Yes.
T incision. That is the first thing we have to understand. They should not put an inverted T incision in such cases. For any case, unless it is indicated.
But most likely the inverted T might have been gone up to the fundus. They said rupture up to the fundus.
Because the uterus size is less, no, not a
ആദ്യം
full term.
തുടങ്ങിയിട്ട് മേലോട്ട് അങ്ങ്
So
പോവുമല്ലോ.
probably it has extended up. Okay.
So instead
Any
of
other point?
inverted T, they can go for either J or U-shaped incision. It's not.
Smiley incision. All preterm, there will not be space, a smiley incision. Both sides you extend and make room.
That is
Always we extend on both sides and give space for to deliver the baby.
That's the best thing to do.
Never go for a T. You have to anticipate and initially itself you put a sufficiently big incision to deliver the baby. That's very, and when such a patient comes with pain, abdominal pain has to be properly evaluated by history and clinical examination. So she might have started rupture at that time.
Clinical examination also you should have you should go for an ultrasound also.
If they have got a documented evidence of inverted T, the first thing you have to suspect is rupture uterus
First
only.
thing you would have suspected. Inverted T എഴുതി വെച്ചിട്ടുണ്ട്. ചിലപ്പോൾ എഴുതത്തില്ലല്ലോ.
ചിലപ്പോൾ എഴുതൂല. അപ്പോഴാ പ്രശ്നം.
So in all situations where cesarean is complicated by extending upwards on one side, both side, or T, or whatever it is, or vertical incident, the lower segment extended upwards, etc., we have to write in the discharge card. And whenever a patient comes with pain has to be properly, you have to take a proper history and properly evaluated. Clinical examination, very, very important.
This patient also, and previously one patient with previous cesarean section, 36 weeks with pain in abdomen given to meningitis syndrome.
അതുകൊണ്ടാണ് ഞാൻ ഈ പിന്നെയും പറയുന്നത്. അങ്ങനെ വരാൻ പാടില്ല. Let us all together make motherhood safe.
Yes.
There are other faculty has joined. I don't know whether any one of them has any comments on this. Dr.
Sangeeta,
Sangeeta, you have left.
ഉണ്ടല്ലോ.
Sangeeta,
Dr.
സംഗീത പോയി
Sangeeta,
പറഞ്ഞോ?
she's actually out of station. She has joined from
she's
there,
in Bangalore.
from
She
Bangalore.
is in Bangalore.
Kunjamma madam join ചെയ്തിട്ടുണ്ടോ? Kunjamma Roy madam.
Yes, yes, I am here.
Madam, you want to say something about the cases we
In
discussed?
fact, it was an elaborate discussion on all the cases, no? I think more to add. I think already the time is up. All the senior teachers.
madam. Madamത്തിന്റെ രണ്ട് expert comments കേൾക്കാൻ സമയമുണ്ട്. You want to say something?
Prasanna Madam has explained and given so many learning points from all these cases, and Radhamani Madam in detail repeated all the findings and gave her opinion. Really appreciate it. And Vinay and all of them, except Vinay, and all of them are my teachers. So I don't want to add anything more. Definitely the learning points like the previous cesarean case or the pain abdomen, in the first case itself, they also already discussed that the need for myomectomy, that I want to emphasize again, no, there was no need for myomectomy in that first case, only small myoma for infertility and soon after IVF done and all the complications. So the what all things we heard, we have to put into a practice, or at least we have to change our practice for the benefit of the mothers, so that we will not have such near miss cases or morbidity. We can very well reduce the morbidity much more if we follow all the points what we have learned. That's all. Nothing more to add to.
Kunjama, for the second case with the chronic rupture, and most likely it will be a help, is it not?
Second rupture, as Radhamani said, it's a slow leak, a gradual leak. Help.
Plus help maybe there.
ലീക്കാണ്
Yeah,
ബവലെഡർ
could be there, but in the initial phase,
ചിലപ്പോൾ ഉണ്ടായിരുന്നിരിക്കും.
initial phase itself, that could have been suspected, that slow leak. That also Radhamani Madam mentioned that the gradual leak.
Early
Yeah.
അൾട്രാസൗണ്ട് കൊണ്ട്
And that's the
Ultrasound,
reason.
everybody discussed the echogenicity or the, like, the ascitic, the fluid, the nature of the fluid that can be assessed by proper ultrasound. No? With that suspicion, like if it is a blood, it would be a different picture. From that, you can make at least a suspicion of hemorrhage and deal accordingly, instead of simply saying that there is ascitic fluid.
അസൈറ്റിക് ഫ്ലൂയിഡ്
So
ബ്ലഡ് ആണെന്ന്
it-
ആ ബ്ലഡ് എന്തുകൊണ്ട് വന്നെന്ന് ആലോചിക്കണ്ടായിരുന്നു. ആ ഇമേജിംഗ്
Other-
did not help her at all.
Yes,
Imaging did
yes.
not help.
Yes, yes.
That's why I'm telling all obstetricians
Yeah,
should do ultrasound.
especially with the history of chorioamnitis and evacuation, definitely we should have suspected a weak fundus and the perforation. It might have been there already, which was healed spontaneously. So every possibility of a rupture or give way of that area. And that was a slow leak. And the covulatory uterus also, it's because of that, no? It's not due to abruption, I think. Because of that slow leak, it was invading into the myometrial
rupture
fibers as well.
There was sufficient time for you to rescue the
Yeah. Yes, yes.
fetus.
Baby was 1.29. We could have well saved that baby if it was done little earlier. And this last case, of course, inverted T, definitely we should immediately think of that rupture only. And this colporexis again, no, there the learning point is that even for normal delivery, not only for instrumental delivery, even after normal delivery, we have to inspect the cervix. See, at that time only, sometimes even without bleeding, we may find some rupture, tear of the cervix. We have seen, yeah. See, one case, the last presentation I have presented, that there was a rent in the posterior aspect of the pouch of Douglas through which omentum was protruding. There was no bleeding at all. Only by examining the cervix, looking for any tear in the cervix, even after a normal delivery, that will reveal such points. Maybe rare, but we have to examine carefully and see and look for any rent anywhere. A vertical cervical tear or a transverse tear such things has to be identified. Earlier, we used to say after instrumental delivery, we have to examine the cervix, but following normal delivery as well. That also is a learning point from the presented cases.
Especially with
Vidima
PG
Madam,
one.
we say that the best time to look at cervical tears and traumatic vaginal tears is after the
Before the placenta
delivery of the
comes.
baby, before the delivery of the placenta. So that's a basic thing. During that time, we should be seeing whether there is any cervical tear will definitely bleed after the baby is born. So once the placenta starts coming out, the blood starts coming out and we get confused. But when the placenta is inside, you find any fresh bleeding, that could be an indication for a traumatic bleeding, especially the cervix which was torn, one sutured, again one was there which was extending up. That case, if we had inspected carefully after the baby's delivery, maybe we would have found out.
Yeah.
Yes.
There can be types of cervical tear. I remember one patient who delivered to the posterior cervix, not through the external loss. Pre-eclampsia use ചെയ്താണ് അത് posterior cervix ഇവിടെ ഡെലിവറി ചെയ്തു. ഡെലിവറി കഴിഞ്ഞ് നോക്കിയപ്പോൾ സർവീസ്
Bucket handle tear.
ബക്കറ്റ് ഹാൻഡിലൊന്നും ഇല്ല, അതിങ്ങനെ അതിനെ കൂടെ ബേബി വന്നിരിക്കുന്നു.
ഞാൻ പറയുന്നതിന് മുമ്പ് ഡോക്ടർ വിനയചന്ദ്രൻ എന്തോ പറയാൻ തുടങ്ങുമായിരുന്നല്ലോ.
Bucket handle tear, that's all.
ഓക്കെ ഓക്കെ.
ഒരു 4 questions ഞാൻ പറഞ്ഞത്. ബക്കറ്റ് ഹാൻഡിൽ പോലെ തൂങ്ങിയൊന്നും കിടന്നില്ല. ഞാൻ വെറുതെ ഒന്ന് നോക്കിയത്, അപ്പൊ കാണാൻ വലിയൊരു തുള പോസ്റ്റീരിയർ സർവീസിൽ.
And my doubt, like, no, it's a cervical tear. If it is the, see, you are suturing from below, and if the apex is not seen once you open the abdomen, if the tear is 3 centimeters above the level, and that can be sutured if no other problem. And if needed, uterine artery ligation instead of going ahead with the hysterectomy. What do you say? What's your opinion?
Yes.
We can conserve the uterus, no? If it is colporexis, secondary colporexis, that is called. So in that case, we are anyway suturing from below and the apex is not visualized, then only we are taking a decision for laparotomy. And on laparotomy, if the lower part of that tear is already sutured from below, you can suture the rest of the tear. And, that way we can conserve the uterus.
So, but you have to make sure that the patient is in the modified lithotomy position. Then only it will be
Fowler's
useful.
position. In all PPH cases, you open with the Fowler's position. Otherwise, you will not see whether she is continuing to be or not. Okay.
Yes.
That's a leading point.
That's right. Yeah.
Otherwise,
Now,
you
there
will
are
miss.
few questions in the chat box. One is induction justified at 39 weeks in cases of, isn't it induction justified at 39 weeks in case of gestational hypertension? Prasanna Madam has already answered this question, and Prasanna Madam and others, that if investigations are normal, no proteinuria, then the BP is controlled.
Unfavorable cervix.
Yes, in an unfavorable cervix, we can wait for some more time after closely monitoring the patient. The second question is, when to start induction in gestational hypertension when investigations are normal? Can we go till term? This is from Dr. Jasmine.
She can go till 10.
Madam.
But
when,
mother and baby should be monitored.
When to start induction in gestational hypertension when investigations are normal? Can we go till term?
Yes.
Can go till term. There is no proteinuria, no organ dysfunction, mother and baby all right, you can wait. If the service is comparable, you can wait till term.
Okay. Now, is mifepristone, misoprostol madam, accepted as an inducing agent at term?
Misoprostol. That case, mifepristone was given as first inducing agent in that fourth gravida. Lateral wall rupture.
Mifepristone.
Yeah.
So is it accepted as an inducing agent? Here in this case, it was used in a fourth gravida.
മെഫിപ്രിസ്റ്റോൺ അങ്ങനെ നമ്മൾ ഉപയോഗിച്ച് തുടങ്ങിയിട്ടില്ല, അപ്രൂവ് ചെയ്തിട്ടില്ല. പക്ഷെ ഉപയോഗിക്കുന്നവരുണ്ട്, ബോംബെയിലൊക്കെ ദിവസേന ഉപയോഗിക്കുന്നവരുണ്ട്. പക്ഷെ
Even
നമ്മൾ
in
ഉപയോഗിച്ച്
Kerala
തുടങ്ങിയിട്ടില്ല.
also,
I think
Rajagiri
Kerala
they are
ഉപയോഗിക്കുന്നുണ്ടല്ലോ
using.
ma'am.
Yeah,
Calicut.
Rajagiri they are using, and some other centers also they have started using mifepristone.
In Calicut
Not in
also.
our hospital. Hmm?
In Calicut, IMCs they are using.
എത്ര 200 ആണോ?
Yeah, 200.
200.
Then leave her for
Oh,
another 24 to 48 hours.
പിന്നെ ഒരു
പ്ലസന്റൽ
ചോദ്യം
ഫംഗ്ഷൻ
ഉണ്ടായിരുന്നു.
കുഴപ്പമൊന്നുമില്ല.
200 misoprostol, can it be given for induction? എനിക്ക് തോന്നുന്നു അതാ ഞാൻ പറഞ്ഞ മിഫിപ്രിസ്റ്റോൺ ആയിരിക്കും തെറ്റിദ്ധരിച്ച് മിസോപ്രോസ്റ്റോൾ
എന്ന് വിചാരിച്ചായിരിക്കും.
പിന്നെ ഒരു വെടി ഉണ്ടാവും.
പിന്നെ റോൾ ഓഫ് ലെട്രസോൾ ഇൻ സ്കാർ എക്ടോപിക് എന്ന് പറഞ്ഞൊരു ചോദ്യമുണ്ട്. റോൾ ഓഫ് ലെട്രസോൾ ഇൻ സ്കാർ എക്ടോപിക്.
What's the role? I don't think.
What is the role?
Letrozole അങ്ങനെ കേട്ടിട്ടില്ല.
ട്രീറ്റഡ് സർജിക്കലി.
ഒരു ബുക്കിലെ റെഫറൻസിലൊന്നും ലെട്രസോൾ കണ്ടിട്ടില്ല. I have not seen. മെഡിക്കൽ മാനേജ്മെന്റ്.
Not heard so far.
അല്ല, what will be the mechanism of action of letrozole?
No, that is a stream only, no? Estrogen enzyme.
Aromatase inhibitor.
Aromatase inhibitors only.
എന്ത് ചെയ്യാന്?
അടുത്ത ചോദ്യം, in multigravida can be induced with 50 micrograms misoprostol. നേരത്തെ ഫോർത്ത് ഗ്രാവിഡയ്ക്ക് 50 വെച്ചു എന്ന് പറഞ്ഞുകൊണ്ടാണ് ചോദിച്ചേക്കുന്നത്. Can be induced with ജയശ്രീ മാഡം കൈ പൊക്കിയിട്ടുണ്ട്. ജയശ്രീ മാഡം, can you put it as a question answer? Two participants have raised their hands. Actually, there is chat had been enabled for the participants. I don't know whether you can put it in the chat box or not. Otherwise, please put it as a question answer, Q&A. You'll be able to put it in Q&A.
ഇതിനകത്തിട്ടാ മതി.
ഇല്ല, or you can put it in the group. മാഡം, നമുക്ക് സെഷൻ വൈൻഡ് അപ്പ് ചെയ്യാൻ തോന്നുന്നല്ലേ? It's already 9:40.
Lakshmi, just I saw googled about the letrozole. Letrozole at a dose of 10 milligram per day for medical treatment of ectopic pregnancy results in high successful rate without any severe side effects. Letrozole depriving the placenta of estrogen that had vascular supportive signals resulted in destroying the vascular network with marked apoptosis.
Yes.
Okay.
Fantastic.
I will go through that. We'll see that.
Thank you.
Next time we can present that letrozole. Somebody asked the question, that is why I tried to get it, because it affects the vascularity of the placenta.
10 milligram for how many days?
10 milligram per day. Just
Per day.
Okay.
Per day, single dose or multiple dose?
Per day.
Per day means multiple doses.
Going details about 10 days. For 10 days.
Okay, okay.
സംഭവിക്കാം.
By that time, it will rupture.
Something can happen to the ectopic.
We name participants have raised their hands. I think if you can put it as a question answer, I think they have put it. Let me see. If not induced at 39 weeks, that pregnancy may go in for IUD, especially in pregnancy induced. No, we don't use the term pregnancy induced hypertension anymore. gestational hypertension and hypertensive diseases of pregnancy. Somebody has expressed the anxiety that if you don't induce them before 40 weeks, the pregnancy may go into IUD.
That's why we
Not
said
always.
there is no proteinuria, no placenta insufficiency, no system involvement. We can wait. And unfavorable cervix. Otherwise, we need not wait. You should be able to make sure mother and baby are well.
Yes, the fetal surveillance
Either
with BBP and
good
Doppler.
fetal surveillance.
It is fine, you can wait.
Ultrasound, Doppler, and CTG.
Yeah.
And mother should be advised to record fetal movements 1 hour after breakfast, 1 hour after lunch, 1 hour after dinner. Left lateral position.
Yes, if she says decreased fetal movement, take it to
Take it.
for yes.
And make sure it is decreased and then only interfere.
Yeah.
But in this
But we
particular
love-
case, unfavorable cervix, then mechanical method of ripening or making the cervix ripe, that would have followed, no? Instead of giving misoprostol and misoprostol. See,
definitely.
at 39 weeks, no, given to me, I would have induced, but unfavorable cervix, I'll make it favorable first with mechanical methods rather than going for misoprostol or misoprostol 50 microgram.
See, that multi they have done with all except ARM.
No, mechanical method.
Yes, I agree. But in that case, they have done everything except ARM for that patient, then waiting for rupture.
The proper method of
നമ്മുടെ
induction.
പണ്ടത്തെ സ്ട്രിപ്പിംഗ് എല്ലാരും മറന്നുപോയ പോലെയാണ്. ഒരു 2 days നമ്മൾ ഇൻഡ്യൂസ് ചെയ്യാൻ ശ്രമിക്കുന്നതിന് ഒരു 2-3 days മുമ്പ് നന്നായിട്ട് സ്ട്രിപ്പ് ചെയ്ത് വിടുകയാണെങ്കിൽ ഒരു PROMന്റെ ഒരു പ്രശ്നമുണ്ട്. എന്നാലും കുറച്ച് സ്ലോ ആയിട്ട് ഇത് ചെയ്യുമെന്ന് എനിക്ക് തോന്നുന്നു. Cervix ripen.
It also has a role. Even now that has a role.
അല്ലല്ല, നേരത്തെ നമ്മൾ ചെയ്തുകൊണ്ടിരുന്ന പോലെ ഇപ്പൊ ആരും അത്രയ്ക്ക് അതിനെപ്പറ്റി പറയുന്നില്ലല്ലോ. അതുകൊണ്ട് ഞാൻ പറഞ്ഞതാ. പണ്ട് നമ്മൾ ആദ്യം സ്ട്രിപ്പ് ചെയ്ത് വിടും അങ്ങനെ ഉണ്ടായിരുന്നു.
PV സ്ട്രിപ്പിംഗ് എന്തായാലും ഒരു റോൾ ഉണ്ട്. നമ്മള് 35
എസ്പെഷ്യലി
സ്ട്രിപ്പ് ചെയ്ത 15 പേര് അന്ന് തന്നെ പ്രസവിക്കും.
വീണ്ടും ചോദിച്ചിട്ടുണ്ട് ഈ 50 മൈക്രോഗ്രാംസ് മൾട്ടിക്ക് ഉപയോഗിച്ചാൽ എന്താന്നുള്ളത്. ഓൾറെഡി സോഫ്റ്റ് ആയിരിക്കും മൾട്ടിയുടെ. അപ്പൊ നമുക്ക് അറിയാൻ പറ്റില്ല 50 കൊടുത്തു കഴിഞ്ഞാൽ അവരെങ്ങനെ റെസ്പോണ്ട് ചെയ്യും, പിന്നെ ട്രോമ ഒക്കെ വരുമോ നമുക്ക് അറിഞ്ഞുകൂടാ. അതുകൊണ്ട് എപ്പോഴും ഒരു 25 തുടങ്ങും.
Lakshmi, we will see more rupture, that's all. PPH.
Some of these cases considered as PPH or referred as PPH, finally on further evaluation, it reveals that it is rupture uterus. So that sort of a suspicion should come earlier than referring from somewhere and then again suturing the cervix and like that. So for that case, cervix was intact, no? The lateral tear of the uterus. But with PPH, they should have suspected rupture even earlier.
Yes, with a multi.
Yeah.
അല്ലെങ്കിൽ ബൗട്ടായിട്ട് വരുന്നത്, എസ്പെഷ്യലി അങ്ങനെ ബൗട്ടായിട്ട് വരുന്ന പേഷ്യന്റ്.
That's for the second case. A lateral tear, the whole lateral wall of the uterus torn, no? And there was a big hematoma. So that case, instead of considering it as PPH, they should have suspected rupture even earlier.
അതാണ് ഈ ലേബർ റൂമിൽ ഒരു അൾട്രാസൗണ്ട് ഉണ്ടെങ്കിൽ പ്രോബ് വെച്ച ഉടനെ നമുക്ക് മനസ്സിലാക്കാം.
Yes, yes.
That is why I'm telling all obstetricians to do ultrasound themselves.
And labor room should have an ultrasound facility.
Definitely.
Madam, it's 9:50. നമ്മൾ 7:50ക്കാണ് ആക്ച്വലി തുടങ്ങിയത്. 2 hours. Maybe we will wind up the session.
Lakshmi, I have a request.
Yeah.
No, next time try to start at the right scheduled time instead of.
Madam, ഇന്ന് എന്ത് പറ്റിയെന്ന് അറിയോ? 2 ഫാക്കൽറ്റിക്ക് കയറാൻ പറ്റിയില്ല. ഓഡിയോ, ക്യാമറ.
I joined at 7:40. I mean 7:20. I was watching, listening to everything.
തുടങ്ങണമെന്ന് വിചാരിച്ചാ മാഡം, അതിനിടയ്ക്ക് ടെക്നിക്കൽ ഇഷ്യൂസ് വന്നു. എനിക്ക് തോന്നുന്നു ഇനി ഫാക്കൽറ്റി ഒക്കെ 7:15 കയറിയിട്ട് എല്ലാരും കയറിയും തോന്നി മാഡം, കയറിയും തോന്നി. പക്ഷേ ശ്രീദേവി മാഡത്തിനും രാധാമണി മാഡത്തിനും ഒരു കുറച്ച് ടെക്നിക്കൽ പ്രോബ്ലംസ് വന്നു.
അതെ, അല്ല കുറച്ചുകൂടി നേരത്തെ കയറുവാണെങ്കിൽ ടെക്നിക്കൽ പ്രോബ്ലംസ് would have corrected by 7:30.
നമുക്കിനി അടുത്ത പ്രാവശ്യം ഫാക്കൽറ്റി എല്ലാം 7-ന് കയറാം. അടുത്ത ഒരു ഫാക്കൽറ്റി കുഞ്ഞമ്മ മാഡം ആണ്. ഞാൻ ഇപ്പോഴേ പറഞ്ഞിട്ടുണ്ട്. കഴിഞ്ഞ പ്രാവശ്യം ഞാൻ പറഞ്ഞതാണ്.
കുഞ്ഞമ്മ നേരത്തെ കയറി, ഇന്ന് കയറിക്കും.
പിന്നെ കേറി.
And we had to begin
കളിയാക്കാതെ.
with 243 participants ഉണ്ടായിരുന്നു.
അതൊക്കെ പ്രതീക്ഷിക്കണം.
അല്ല, എന്റെ ഒരു നേച്ചർ അത് നേരത്തെ കയറുക എന്നുള്ളത്. അല്ലല്ല, കുറെ പേര്, more than 100 people were waiting.
അതെ.
അത് ഈ പ്രശ്നം ഉണ്ടാ കുഞ്ഞമ്മ.
നമ്മൾ അടുത്ത പ്രാവശ്യം അത് കറക്റ്റ് ചെയ്യാൻ നോക്കാം മാഡം.
അല്ല, സോറി, ഞാൻ പറഞ്ഞ ആരും ഫീൽ ചെയ്യില്ലേ. ഞാൻ ജസ്റ്റ് ഒരു
നമ്മൾ we were also saying that ഡോക്ടർ വിനയേന്ദ്രൻ പറയുന്നുണ്ടായിരുന്നു കുറെ പേര് വെയിറ്റ് ചെയ്യുന്നുണ്ട്, ലെറ്റർ സ്റ്റാർട്ട് എന്ന് പറയുന്നുണ്ടായിരുന്നു. നമ്മളെല്ലാം 7:15 കയറി മാഡം. നമ്മളും കയറിയായിരുന്നു.
വില കൊടുക്കണമല്ലോ.
ഓക്കെ.
എന്തേ
ഏതാ
പ്രസന്ന മേഡം കടവിലിരിക്കുന്നവരുണ്ടല്ലോ, നമ്മുടെ
കടവിലിരിക്കുന്നോ?
ഇരിക്കുന്ന പോലെ ഉണ്ടെന്ന് ബാക്ക് കണ്ടു കഴിഞ്ഞാൽ.
ബാഗ് അത് ഒരു വോളാ എന്റെ.
ജസ്റ്റിക്കോണ്ട് കാണാം അല്ലേ?
ഞാന് കാറിൽ വരാന്നാ വിചാരിക്കുന്നേ. ട്രെയിനിൽ കയറാൻ പറ്റും, ഇറങ്ങാൻ പറ്റത്തില്ല.
ശരി,
അത് പാടാ, കാലുണ്ടേ. വരും ഞാൻ എല്ലാരും കാണാൻ.
കണ്ണൂർ എയർപോർട്ടിൽ വന്നാ മതി. കണ്ണൂർ
എന്ത്
എയർപോർട്ടിൽ വന്നാ മതി, നമ്മൾ അങ്ങോട്ട് കൊണ്ടുപോവാ.
നോക്കട്ടെ.
എന്തായാലും വരണം.
എങ്ങനെങ്കിലും വരും.
So thank you all the faculty for spending so much of time with us and for the excellent discussions we had. And I would like to thank the delegates also. Of course, the number has increased from last time. Anyway, our aim is to make it at least 500 by the time we come to the end of the webinars. Anyway, we will keep trying to include more people.
എല്ലാ
എന്താ മാഡം?
All obstetricians should attend. Obstetricians, endoscopist വന്നില്ലെങ്കിൽ endoscopisറ്റിന് വേണ്ടി കുറച്ച് കാര്യങ്ങളൊക്കെ നമ്മൾ പറയുന്നുണ്ട്.
So, Prasanna Madam, Radhamani Madam, Sridevi Madam, Dr. Vinay Chandran, thank you all. Thank you very much. And Dr. Mini, thank you for the presentation. And Sujitra Madam, especially for staying back till now. I know you have told that it's a learning point for you also. Dr. Subhash Malia Kunjumoidin also had joined. And Dr. Ajit ne onnum parnillalo. Ajit was there nu ഞാൻ വിചാരിക്കുന്നു.
അജിത്ത് ഉണ്ടായിരുന്നല്ലോ. അജിത്ത്
ഇടയ്ക്ക് വിളിക്കാമായിരുന്നു, ഞാൻ മറന്നുപോയി. എനിവേ താങ്ക് യു ഓൾ.
ഊണ് കഴിക്കാൻ പോയതായിരിക്കും.
ഊണൊക്കെ കഴിച്ച് വന്നതായിരിക്കും.
ഡോക്ടർ അജിത്ത് എന്തെങ്കിലും പറയാനുണ്ടോ?
ഫോർത്ത് ഗ്രാവിഡെ ഇൻഡ്യൂസ് ചെയ്തിട്ടുണ്ട്. I think personally I would have induced at 39 weeks. The only thing is the way we induce, we will put a Foley's mechanical.
Foley's.
And rather than giving 50 microgram, 25 microgram misoprostol.
ഞങ്ങളൊക്കെ സാധാരണ gestation hypertension 39 weeks induced with Foley's ആണ്.
Even other cases also we are inducing. So this hypertension also ഒരു ഡിഫറൻസ്.
ഞങ്ങൾ ഇൻഡ്യൂസ്
എല്ലാ കാര്യങ്ങളും വളരെ നല്ലോണം പറഞ്ഞു.
പ്രസന്ന മാഡം എന്റെ ഡോപ്ലർ ഒക്കെ നോക്കി ഒരു ഷുവർട്ടി ഒക്കെ കൊടുക്കും. അപ്പൊ കുറച്ചുകൂടെ വെയിറ്റ് ചെയ്യാം. എന്നാലും BP ഒരു ബോംബാണ് മാഡം എപ്പോഴും. നമുക്ക് പറയാൻ പറ്റില്ല. ബട്ട് മാഡം സെഡ് അൺഫേവറബിൾ സർവിക്സ് ആണെങ്കിൽ വെയിറ്റ് ചെയ്യാം എന്നാണ് പറഞ്ഞത്. ഫേവറബിൾ ആണെങ്കിൽ ഡെഫിനറ്റ്ലി ഇൻഡ്യൂസ് ചെയ്യാം. അൺഫേവറബിൾ ആണെങ്കിൽ മെക്കാനിക്കൽ മെത്തേഡ്. അടുത്ത പ്രാവശ്യം ഡോക്ടർ അജിത്തിനെ ഞാൻ ഓർത്ത് നേരത്തെ വിളിക്കാം. ഡോക്ടർ അജിത്ത് ഇസ് someone who speaks only when spoken to ആണ്. അല്ലെങ്കിൽ മിണ്ടാണ്ട് പതുങ്ങിയിരുന്നാളെ. എനിവേ താങ്ക് യു. ശരി. So good night.
Congratulations. Good night.
എല്ലാവർക്കും സ്പെഷ്യൽ താങ്ക്സ്.